We are extremely pleased to welcome our revered professors, our colleagues, and everyone present here. Thank you all for your precious time. Well, let's start with today's proceedings.
First on the agenda today, laparoscopic surgery has existed since the development of diagnostic laparoscopy in the 1960s. The procedure has become the gold standard for many organ systems. Significant improvements in surgical training as well as development of the instruments, imaging and surgical techniques have made laparoscopic surgery safe and feasible across the different medical fields.
Yes, requesting Dr. Dheeraj R. Balyan sir, Professor LLRM College, to familiarize us with the advance of laparoscopy. Please welcome our first speaker of the day with a huge round of applause. Sir has done fellowship in surgery oncology, hepatobiliary surgery, upper GI surgeries, bariatric surgeries, hepatobiliary pancreatic and GI surgical oncology. Former CMS and COVID hospital in charge of LLRM College. This session will be chaired by Dr. Sandeep Kansal sir. Please welcome sir on stage.
Good morning, everybody. First of all, I would like to thank the organizing team to give me the opportunity to present this topic on laparoscopy. And order with my research, I am entitled to present on the basics of laparoscopic surgery. Today we know every patient that comes to hospital with some surgical illness, he will say, I want with laser. Means general population is learning with the surgical attitude, they want things advanced. Laser, like they call laparoscopy to laser, so they have to go with their expectation. So, to continue I'd like to introduce laparoscopy, basically advancement of this technology, innovation and skill. And every surgery of abdominal, thorax and cardiac surgery one can be done very well with laparoscopy if we are sticking with the principles of laparoscopy. So these are the advantages. Main advantage basically minimal invasion of body. When we are giving incisions, like people can be done with laparoscopy very well, and we can compare incision of people, some bilateral subcostal incision with 4 ports of laparoscopy. So when we are reducing trauma to the patient, and trauma not only trauma of this ports, we are reducing the trauma of our retraction. Those are hidden basically trauma. When you are retracting your chest wall or abdominal wall with our retractors, they are giving soft trauma and they lead to very severe post-operative pain to patients. And most of the patients of these laparotomy, they are having chest problem, chest failure, respiratory failure in these cases. So to reduce these pains, and we are reducing the pain, then patient will command everything. You will be asking to move, he will be mobilized, he will take oral, he will be psychologically build up, and everything will be reduced with this advantage of laparoscopy. So we are reducing incision, we are putting ports and giving minimal invasion to body, then we are having real advantage of laparoscopy. Risk, if we are going carefully, although these risks are written, but they are not too much. They are hardly 2% in cases of laparoscopy. Slightly risk of collateral injury. If we are having good instruments with insulation of their seats, there will be lesser chances of these lateral injuries. Bowel, bladder, and with proper learning and proper training, these risks are very rare, like varus needle injury. If we are not putting varus in abdominal cavity because of fear of risk, most of the time we will be going blind with trocar and there will be higher chances of injury. So, risks are there, but with careful installation of these things, risk will be reduced. That may lead to organ damage because of coupling, already covered, increased operating time. When we are starting the things, has given long learning curve with due course of time. This timing of operative procedure will be less. Although these are not risk of laparoscopy, but some pair were written. But with proper training and proper adherence of the principle of surgery, timing will be also reduced. And tumor seedling, of course, in case of advanced malignancy, most of the time we are doing laparoscopic cholecystectomy and incidental gallbladder cancer may be found. And in these cases, maybe there is risk of seeding. But if we are removing these specimen in bags, these risk will be also reduced. Limitations, loss of tactile feedback. Really, this is the only limitation we can say. We are not feeling things in our hand. We are relying on the instrument. But if we are doing surgery after 5, 6, 7, 8 years, this tactile feedback can also be perceived by your instruments also. Although all these are the game of experience, and loss of tactile feedback will be not a good big problem. Dependence of hand-eye coordination. We are driving a car. We are totally dependent on your hand-eye or eye-foot coordination. So if you are driving good car, good driving of the car, you can do with good hand-eye coordination laparoscope. Laparoscope is simply doing driving a car. You are comfortable with car, you are comfortable with laparoscope. Difficulty with hemostasis. Yes, in open surgery, we are comparing open surgery in case of hemostasis. Laparoscopy really is a difficulty, but with the adherence of again principles, you are putting a gauge piece, all those things, and good suction, irrigation, these things can be very well covered. But these are the difficulties and limitations of laparoscopy. You cannot convert because of this bleeding. If you are struggling, then you can. Otherwise, with good irrigation, good suction, and with use of gauge pieces, you can, with compression, we can go with most of the bleeding problems. Reliance of new techniques. Yes, we have to be reliable. We have to rely on these techniques. We are advancing the things. In case of poetry, you can say now thunderbeats and harmonics are coming, and there will be. This is to say we are on dependent on new techniques, but we'll have to improve the things. We'll have to go with new techniques, and with use of harmonics and thunderbeats, all these things will be very safe in case of bleeding and everything. Extraction of large specimen, yes, but we can. Most of the specimen 3 to 4 centimeters incision, like kidney donation. If we are comparing a laparoscopic donor nephrectomy and open the nephrectomy, you will see there will be hardly 3 or 4 centimeters. Dr. We can tell very well. 3 or 4 centimeters incision in suprapubic area, we can retrieve big specimen. Like bariatric surgery, we can remove all sleeve mastectomy specimen with umbilical cord 15 millimeters. So extraction of large specimen. In case of malignancy, we are really struggling, but morcellators and specimen in bag we can do. But these are some limitations in case of beginning. In case of long experience, we are not struggling on these things. But in the beginning, we are struggling. Spectrum, every case, as we have already told, every case of abdomen except procedure section can be very well taken with laparoscope. So, diagnostic TB, diverticulitis, lymphadenopathy, benign renal disease, gastric outlet obstruction, although they can be diagnosed with other modality also. And in operative cholecystectomy, appendectomy, bowel resection, repair of prolapse, nephrectomy, bypass, VATS, even cardiac surgery, robotic bladder, robotic prostatectomy, and new bladder, everything can be done with laparoscopy with good training and with the adherence to with the acceptance of advanced technology. So to do the things, we have to know ourselves, our equipment, and our patient. So our equipment is laparoscope, and you are seeing this telescope. With the beginning, we are using 0 degree. 0 degree means forward looking, but with advancement of the cases to increase the field of vision, companies have changed to 30 degree, 45 degree, and 70 degrees. These are basically these angle scope basically increases the field of vision. When you are doing simple cases, there is no problem, but when they are getting 30%, falciform is hanging, liver is hanging, and you are not seeing, so you can make the angle and you can go very well with the Scalest angle or anything we can do. So these are the camera head of it. In camera, first with the invention there was single chip, now 3 chips HD. These are technology we are using, and now you can see 10 years, 15 years we are seeing red and white things. But now as we go in the abdominal cavity we are seeing CVD very well. Otherwise 10, 15 years back we are not seeing CVD. In case of laparoscopy, now you are putting a scope, you are seeing CVD, cystic duct, everything is already seen because of the technology and high pixel cameras and telescopes. In case these are the camera head you are seeing, first when we are introducing, we are coupling telescope with camera, we have to clean both interface of this telescope and camera. Most of the time in beginning we are not doing these things and we are struggling in intra period because of fogging and blurring of these things. So before joining the telescope and camera heads, you have to clear the interfaces. You have the light source. The light source is we are using today LED source, light using diode technology, and they are giving natural light, and bulb is also bulb life is also long, and they are giving totally natural colors. We compare 10-15 years back, we are giving yellow, xenon light, halogen sources, their light was not good. So reliance of the new technology, which is not a failure, these are basically giving good care to the patient and less struggling in operatively. Getting space in abdominal cavity. This is like giving an incision. You have to decide how to enter. In beginning, as my topic is basic, so I would not like to go common space or difficult cases, but we have to make an entry in supraumbilical, in umbilical area, supraumbilical behind umbilical, because umbilical is the point of weakest point of the abdominal wall. There is no myofascial things behind umbilicus. So putting an transverse or vertical incision 8 to 10 millimeter, and we are lifting up this umbilicus with some non-traumatic things or some Ellis force, and we are putting various needles behind the umbilicus. So there is a lesser resistance and least adherence behind the umbilicus will be, and this is the most important. Otherwise, in case of difficult cases, we can go with open technique, and if previous abdominal surgery has been done, we can go use palmar points to enter abdominal cavity. Okay. To distend, you have to insufflate the things we are using carbon dioxide, and worldwide carbon dioxide is the main use. Otherwise, air, nitrous oxide, I don't think anybody is using this. Carbon dioxide is universal, and carbon dioxide is giving no injury and time-tested things, so we'll have to rely on carbon dioxide. Ideal property of gas: inert should not burn the things, diffusible in blood so that can be expired by lung, easily available and easy manufactured. The carbon dioxide is least the cheapest thing we can use and we can get from anywhere. Insufflator, these are the arrow. See, they have to keep pressure. Between 10 to 15 pressure is adequate, and anesthesia is saying, if please keep pressure low, you can go with 10, 9, you can do very well with the, you can go very well with the pressure. Otherwise, 14, 15 pressure is very good to withstand the things. But according to patient and according to your anesthetist, if they are facing some problem, cardiovascular or respiratory problem regarding the distension of abdomen, we can reduce pressure, and things can be done at 9 or 10 millimeter of mercury also. And these are the things we are seeing here: total pressure, total insufflation, total gas use, and insufflation problem. They are not problem. Basically, they are the effects of distension, increased arterial pressure, systemic resistance, cardiac output decrease, heart rating, they are the basically things of anesthesia concern. They will be taking care of all these things. But to know the things we are operating patients have to keep the mind that these things going to happen. So before starting, we are having a PAC. Everybody is doing PAC and consent. So if cardiac problem is there, we have to consider all these things intraoperatively also. If the patient is having these problems before operation. And on lungs, peak, inspiratory pressure increases, pulmonary compliance reduces, that's because of uplifting of diaphragm, vital capacity increases, functional respiratory, and these things can be taken very well if good PAC has been done, patient is fit. So these problems are less important intraoperatively, but to keep it in mind is important, and anesthetists will be well aware of all these things, so procedure will go safe. Instruments. Venous needle. This is the main instrument to enter in abdominal cavity. So before putting, you have to take its splunging action. If it is working or not, and this knob you have to keep in line so that we can use syringe to clear the things. Many times you are putting the venous needle and knob is turned off, and you are seeing that pressure is not going. So these things, know your instrument first. Is not the work of the technician, it's the work of ourselves also. You have to keep everything in mind how our instrument will work. Technician must not be your leader in the procedure, otherwise there are chances of failure. Most of the time you have to lead the thing, whether just to say this is not our work, this is not our work. You have to keep everything in our command to do the things in the best way. So cleaning this venous needle and splunging action, and after putting venous needle in abdominal cavity, you will have to check there is a pre-block, water or pre-block line. You are lifting the abdominal wall and blood is going resistance free in abdominal cavity, so you are in proper place. And these are the trocar, the one trocar, the most important, the optical trocar is not seen here. Now in difficult cases when obese patient is there, optical wall is thick, so you can go with this optical trocar, putting your telescope in trocar, and you go layer by layer, all facial layer, fat layer, and pedal cavity will be very well seen, and you will be entered safely in abdominal cavity. So these are instruments 5 mm, 3 mm, 10 mm. Most of the time, in case of laparoscopy, when we are starting, we are using 5 mm or 10 mm, and before putting, after giving this incision of the venous needle, you are putting next trocar. So to measure the length, you can put trocar on the abdominal wall and make the mark, and your incision must be in this mark. So your incision will be neither will be short nor will be long accordingly. The 10 mm you can put 10 mm mark in this epigastrium, and then with 11 number. So they are the properties of safety trocar, and there's a cork screw trocar. These things actually work initially when you are starting with, when you are trained. Most of the things you are using cork screw or plain trocar, there is no difference in your outcomes and your procedure. These are hand instruments, and with my personal opinion, there must be no use of traumatic instruments. In initial stages, complete person will come to you that will be having good grip. Their tooth instrument, they will be giving you tooth instrument, will be having good fundus instrument. Most of the time they injure the thing, they will be bleeding, or PJ is placed, you are holding appendix, or accidentally you can hold bowel, so there will be higher chances of injury. So my personal request to everybody, beginners, to use non-traumatic instruments. Although there will be some difficulty in holding, but your result will be good and your injury chances will be lesser in case of surgeries. So these are like open instrument, right angle, bowel, fossa, bowel gas, spermatic line, everything is there. It's a comparison of basically open, and scissors, hook, plane, they are making no difference and the needle holder, poultry system, and one thing to mention, have to keep bipolar on our table every time in more action. Most of the time we are doing laparoscopy, if we are doing appendicectomy, it will be your requirement. But in case of laparoscopy cholecystectomy, most of the people are not having bipolar ready on their table. Because most of the time liver ooze, everything can be very well taken. Liver bed, oozing will be taken very well with bipolar. Otherwise, you will be taking hook, Maryland, they will be having higher chances of it. So bipolar is a good instrument, and every beginner should have a good bipolar instrument on their table, on their armamentarium, and ready. Because most of the time they are not there and you are struggling. Hemostasis and bleeding, they are the basically most common cause of conversion to open. So we are using things there in good coordination, so safe exit will be there. Hope and good quality instrument. 3,000, 4,000 people are selling, but they are not of good use. Hope there will be good transmission of energy, good functioning of jaws. In early phase of this is a paradox. In early phase you are using cheaper instrument, and you should have good instrument in early phase, in beginning. When you are master, you can use anything. You will be versatile. But to begin with, really should have good instrument. Your confidence will be high, your output will be high. Later on, you can change to versatile surgeon, and you can use instrument with versatile. But early phase, have a good instrument. So hook like this Maryland, they should be good functioning. Maryland will be a right hand instrument in every surgery, and if you are using good instrument, noting everything will be very good, and your confidence will be high, and there will be less chances of failure. Harmonic is an ultrasonic coagulation and cutting device, and now most of the students, I think, Subharti is also having in their OT. Sandeep told me is a very good instrument. But if you are starting with laparoscopic cholecystectomy with harmonic, it will not be a good suggestion. Where you are using medical cholecystectomy, you are doing liver resection. So these are the things must be on table. But bipolar and monopolar coronary, they are things they cannot replace these monopolar or bipolar. They are for advanced surgery, and we must be aware and we must use all these things. Suction irrigation, these are the things just to show, otherwise everybody using in open surgery also. Suction instrument is, it is not only for suction. Most of the time you are struggling with acute poly, then suction instrument will be the best instrument. It will work as Maryland. You are sucking and you are removing with shaft or tip. Most of the time the suction will be done with suction. You are seeing videos of experts with a difficult poly, then you will notice that right hand instrument is most of the time suction. So good suction tip 5 mm. This 5 mm is very good. 10 mm actually failure. When you are putting 10 mm, they are sucking all the gas. Otherwise, tip should be tip in collection. When tip come out, your gas will be out. You will be seeing that. So 5 mm suction device, suction tube is very important, and they are very good friend of surgeon. They are dissecting also. And although these can be considered as advanced, but I would like to say this is the basic. If we don't have knowledge of a good noting intercorporeal, we will be struggling at any point of time in even a simple poly. So good noting, intercorporeal noting, C loop, reverse C loop, basic principle we are doing. We should learn the things. with noting, if you are not doing good noting, we will not be confident in laparoscopy. Many times you have to do noting, and we can reduce the basically cost of surgery when we are using these things. So to beginners, I request that they should learn noting. Intracorporeal, and this is not a big deal. And the rotors know. Extracorporeal not making. To be honest, I learned this thing. Rotors not making a loop of rotor. I have tried with myself. If anybody postgraduate want to learn, I will teach you after this lecture. But this is very good when doing laparoscopic appendicectomy and the difficult Foley when your clip is not working. And I would like to request you, when grip is out of this human, so please don't clip the thing. Means you are not going to clip. So these are the basically things when you are need these good noting, whether intracorporeal noting or you are doing fundus first, you have removed gallbladder, you are making rotors through and put the things on dilated or inflamed cystic duct after clearing stones from cystic duct. So noting intracorporeal, extracorporeal is very important for beginners. If you have done all these things in beginning, your journey will be safe and your confidence will be high. You will be doing laparoscopic people also with my conditions. So to discuss some procedure, very important is laparoscopic cholecystectomy. These are the anatomy. These are the basically indications. Everybody knows well. Simple gallbladder stone, acute cholecystic gallbladder stone, accompanied with gallbladder atrophy, gallbladder polyps, a calculus many times, silent gallstone. Polypoid lesions, polyps are coming very quickly now because of the easy availability of this. So pre-operative preparation, first of all, good consent. I have to teach patient that there are chances of 78-98% we will be doing it laparoscopically, but written and verbal consent with proper all possible conversion or possible complications. You have to discuss with patient and then you will take a written and verbal consent. And chances of inoperability or chances of conversion have to discuss with open mind. Chances है कोई भी आएगा आज की डेट में यही कहेगा कि I want laser or laparoscopy. Nobody is ready, but you have to convince them. There are chances of bleeding, there are chances of duct injury, there are chances of bowel injury. All that they are very minimum. अभी तक हमने इतने किए हैं, कभी किसी को दिक्कत नहीं हुई है और सब ठीक हो जाएगा. पर फिर भी बताने के लिए आपको 1-2% चांसेस है कि ऐसा हो सकता है, तो हमें ओपन करना पड़ेगा. So these are the words we have to discuss with. And after this, then patient will say, okay doctor, go with your words and go with your skill, and I hope and we hope that you will do better for us. And these words from patient will increase your confidence, and most of the time things will go accordingly. But a written and verbal consent of conversion and all possible complications you have. Because we are facing the things कि CVD injury हो गई या कुछ भी हो गया, bleeding हो गया और हमें पहले नहीं बताया था, नहीं बताया था, तो ये सब चीजें आपको पहले ही डिस्कस करनी है. कंसेंट लेना कि हमने बता दिया मरीज को कन्वर्जन का कि वो कराएगा नहीं, ये बात अलग. बट टू बी सेफ, टू हैव a clear mind during operation, if you have taken good consent, your confidence will be high and really your cholecystectomy will be done safely. But आप उसको हिडन करके कि बताए ना, उसे बता दें कि नहीं कुछ नहीं होगा, दूरबीन से हो जाएगा, ये हो जाएगा, तो बिगनर्स के लिए कह रहा हूँ कि कंसेंट बहुत जरूरी है. कंसेंट वो मरीज के लिए नहीं होती, वो आपके लिए भी होती है. उसके पीछे जो फजीलत होती है वो आपका सारा टाइम पी जाएगी. ठीक है, तो प्लीज बी अवेयर ऑफ ऑल दीज वर्ड्स. biliary, bleeding, bowel injury, all the chances are minimum. आप 1% से कम बताइए, कोई दिक्कत नहीं, बट आप बताइए जो. ठीक. Technique is 4-4 technique. डॉक्टर पांडे 10 मिनट में कर देते हैं, डॉक्टर शशांक आधे घंटे में कर देते हैं, डॉक्टर ये कर देते हैं. These occupied, preoccupied thoughts should not be in your mind. Have to do things safe. Safety of patients is must. ये तो 5 मिनट में हो जाएगा, ये 15 मिनट में हो जाएगा. इन चीजों को आप मत रखिए बिगनर्स के दिमाग में, क्योंकि अपने सीनियर्स को देख वो ये नहीं देखते कि उनको करते हुए 20-25 साल हो गए. तो इन चीजों को ध्यान में मत रखिए. प्लीज गो विद सेफ्टी एंड एडhere टू प्रिंसिपल्स, एंड you will be also doing things in 5 minutes or 2 minutes also with faster than Dr. Pandey and Dr. Shashank. So, but don't try to be Dr. Shashank and Dr. Pandey in your early stage of career. The other steps of cholecystectomy we are seeing every day in OT. And the port side, first port we have an umbilical port. You can make a transverse or longitudinal incision with insufflation of gas with the help of Venous needle. If you are facing difficulty breathing, go with the open technique. And after insufflation of gas, and you are putting this telescope. And I have already told both interfaces of camera and telescope, they should be clean. These are the basic things we are missing in the routine practice. And clear your tip of telescope very well. Dip in your hot water. Please keep a hot water bottle in your table. Sterile hot saline your water on your OT table. But most of the time fogging is there, and you are putting in hot water kettle, and then again this fogging problem will be removed. And sometimes we are using betadine, but you can use betadine if you are comfortable, and you can use this hot water. Then second point, most important, where to put. High up in the epigastrium. High up in the you are feeling the diaphragm. And high up in the epigastrium, a little bit right. A little bit right. Right, high up. So your angle should be this, not this. Your angle, you have to make triangle with things where we are working, like in open surgery. If you focus on open surgery, you are again working on the triangle. Your eye and your hand will be this. You will be doing never surgery. You are doing your open or laparoscopy. Surgery are same, basically instrumentation is same. You have to keep the things on the triangle. Your telescope this side and your instrument. If you are putting low this epigastral port, your hand will be like this, and you will be not doing anything. So to go up on the color triangle, you have to keep the things right high up in the epigastrium, a little bit to right side. Then after putting this port of epigastrium, you will change in position. Keep table, OT table as such as low as possible. As low as possible. Your, I think ergonomic concept will be clear to everybody. Your hand should be like this. आपके हाथ ऐसे नहीं होने चाहिए सर्जिकल. Hand should be like your umbilical level से नीचे आपका umbilical level पे और umbilical your hand should be like. ठीक है 5 मिनट का प्रोसीजर होगा आप ऐसे कर लेंगे. If you will be struggling in some cases you want to do big surgery laparoscopically, in this position you can do it. So putting port and doing things in comfortable manner, you have to keep this position. And this position can be achieved table height as low as possible. ऐसा तो होगा नहीं, कोई जमीन पर चली जाएगी, इतना ही आएगी. अच्छी कंपनियों, अच्छी कंपनी का बल्कि टेबल डाउन अच्छा होता है. जो हमारी कंट्री में है या वैसा कहते हैं उनकी टेबल अपने आप इतनी ऊंचे मरीज देखते हो यहाँ चला जाए और आप ऐसे सर्जरी आप नहीं कर सकते. हैव टू कीप टेबल एज low as possible with head side position up and right side up. So your momentum with its gravity, its weight will be down, will be pulling colon down, will be putting stomach down, and your gallbladder will be visible. If gallbladder is visible after doing this maneuver, there are higher chances of success. If gallbladder is visible after putting laparoscope, so this takes a guarantee, I can say, that laparoscopy, cholecystectomy must be done in this. There are lesser chances of control. कि इतनी एनाटमी अगर आपको 2 पोर्ट डालने पे ही दिखाई दे रही है, एनाटमी तो डिसाइड करनी है, अगर वो इतना दिखाई दे रही है तो देयर आर हायर चांसेस ऑफ सक्सेस ऑफ लेप्रोस्कोपी अनटुवर्ड इवेंट कैन हैपन इन ड्यू कोर्स. So second port is very important. Have to go high up, little right, position and then hand side up, table height as much as possible. Your hand must not go beyond your body like this, like that, and you have to keep at the umbilicus level. You are like, this is like a car drive. You go, if you want to go Agra and have to drive 3 or 4 hours, so you will be having a good position, good driving seat. So ऐसा ही लेप्रोस्कोपी में करते हैं. You have to make things in this manner. Then second port, अब देखिए ट्रायंगल टेक्निक, ट्रायंगल बना हुआ पूरा इसका umbilical port का एप्लीकेशन. तो यही बनाना है. these are the variable. अगर आपने देख लिया फिर आपको अपने आप ही करना है कि मेरा हाथ कहाँ से, किस तरीके से मैं कलर ट्रायंगल को क्वाड्रेंगल बना सकता हूँ, किस तरीके से मैं थके ना मेरा हाथ ऐसा रहे. these are the 2 port are variable, but we are putting not in line toward foot end, and to make this triangle, to make things very well, so that we can make CVS, critical view of safety of Strasbourg, so that posterior wall dissection, interwall dissection, posterior window can be seen. This port, second port is the ventricular port is for left hand, and left hand is basically in laparoscopic surgery your assistant. Open surgery, in open surgery left hand work is done by your assistant. In laparoscopic surgery there is a big difference. You are doing everything yourself. Nobody is to assist you. So your left hand must be dominant and must be good working. Your left hand, you are making notes, you are moving the things like posterior window देखना, anterior window देखना, तो आपका लेफ्ट हैंड अगर अच्छा काम नहीं करेगा तो ये सब चीजें आपका तभी होगा. आपने पोर्ट अच्छी जगह डाला है तभी आपका लेफ्ट हैंड भी काम करेगा. And fourth port is basically have to keep in mind colon, ascending colon के ऊपर से और लिवर का लोअर बॉर्डर हो उसके बीच से चला जाए, ताकि आपको ड्रेन भी रखना है तो एक वो ग्रेविटी डिपेंडेंट. We have given the name of metabolic angle. लिवर का बॉर्डर है, कोलन है, उस एंगल के बीच से आपको ये पोर्ट डालना. And one important thing is the length of trocar inside the abdominal cavity. As minimum as you can. जितना कम उसकी लेंथ होगी उसकी मोबिलिटी उतनी ही ज्यादा होगी. आपने पूरा पोर्ट अंदर डाल दिया. दूसरा मिस कर दिया कि हैव टू बी एट राइट एंगल टू सरफेस व्हेन यू आर पुटिंग. जितना भी आप इसको कर्व कर देंगे या जितना भी आप टनलिंग करेंगे उतना ही इसकी मोबिलिटी कम हो जाएगा. प्रिंसिपल ऑफ फिजिक्स. हैव टू मेक विद दिस रोटेटिंग हैंड, रोटेटिंग रेशियो, put trocar in right angle to surface. If you are putting this epigastrium port, put right angle at the surface of the abdominal cavity, and in this motion, not this, have to go in this manner. In this manner, जितना भी आपका right angle के नजदीक होगा ये एंगल 80, 85 और right 90, उतना ही आपके इंस्ट्रूमेंट की मोबिलिटी अंदर की तरफ ज्यादा रहेगी. जितना ही आप abdominal wall के थ्रू ट्रेवर्स करेगा उतना ही इसकी मोबिलिटी कम हो जाएगी and you will be struggling. So these are the basic things how to put this trocar. कैमरा जाने के बाद में सारा यही है कि आपने ट्रोकार कैसे रखा है, ट्रोकार की पोजीशन क्या है, वो आपकी गारंटी लेता है कि आपका प्रोसीजर अंदर कैसे होने जा रहा है. So put this trocar right angle, near to right angle, slightly right to midline, high up in epigastrium. These are the words of Professor Moria from Agra. I have seen his video 10 years back, and he has very well said, high up in the epigastrium quadrant. And these are the words I am repeating with due regard to Professor Moria. And this is, I think, this is the way to transmit, to channelize the knowledge you are acquiring and you are spreading. So these trocars and things making triangle or color triangle, and this will ensure your safety and course of your procedure. Lifting up these bundles, and if you have keeping the patient fasting overnight, will be distended gallbladder. Neck in stone in neck, there will be distended gallbladder. So there will be difficulty in holding. So in these cases, you can aspirate gallbladder with a safe manner, so that there must be no space in middle. When you are aspirating, you can hold very well, and then make this wonders to our shoulder. Basically to see this color triangle. And now for doing that, please. Hey man, make this triangle to quadrangle. In the beginning, we are focused on color triangle after entering in this approach. This must be not the goal. Goal is in particular. होता क्या है, शुरुआत में देखते ही पूरा एकदम दो हल्के हल्के चिपके और अपना डाल दिया पैरेलल इनके सिस्टिक आर्टरी, ऐसा नहीं. Have to go with in particular. Have to do in particular dissection anteriorly and posteriorly. In particular dissection होने के बाद में, and you are seeing the luvius sulcus and the base of fourth ligament, we have to be above this line, and both these things are very well visible after making good position. Start with posterior dissection in mandibular area, not in callus triangle. I'm again callus triangle, दिमाग में सबको callus triangle रहता है, जाते हैं तुरंत उसमें मारते हैं, वहीं पे ही दिक्कत हो रही. We are going in mandibular. Have to dissect proximal 1/3 of this gallbladder, medial 1/3 of gallbladder, and medial 1/3 of gallbladder is in mandibular. We are doing in mandibular. Posterior dissection करते जाइए, retract करते जाइए लेफ्ट हैंड से. मैंने कहा था लेफ्ट हैंड को डोमिनेंट बना, इसको करके पलटते जाइए. जितना आप करते जाएंगे, लिवर तक चले जाएंगे, तो फिर आपका इंटीरियर डिसेक्शन कुछ बचेगा ही. And we are doing in this is the landmark for this. We are not focusing on callus triangle. After doing this posterior dissection, we will go posterior dissection, you are seeing, and then after you have to move a thin layer of this anterior peritoneal fold, and both the things will be clear. Your gallbladder will be 1/3 of the gallbladder will be away from gallbladder, and most of the anomalies, aberrant right, aberrant duct, aberrant hepatic duct, they are posterior. So you are doing posterior dissection first, then they will be visible, and you have to do the thing safe. So safety profile now standard is this posterior dissection first, anterior dissection first, anterior dissection, posterior dissection of mandibular, not callus. When you are clearing these things, then you are seeing lymph node, landmark for cystic artery, and removing all these peritoneal folds, there will be very good clearance of the cystic duct, cystic artery. So posterior critical view of safety, when you are doing posterior dissection, you are seeing very well the cystic artery and cystic with 10-15 cases. After 10-15 cases, all these things will be. There are little chances of posterior branch of cystic artery, but they are minimal and you can take very well. You are using bipolar, I have already said you have to keep bipolar on the table. Then and you can see two things only entering in gallbladder, and in between these two things you are seeing liver. This is the best view and this is the critical view of cell. And we are adhering to these principles, there are lesser chances of, lesser and lesser chances of. Although not, you are not 100%. But when you will be sticking all these principles, simple poly, you can go this way, that way, no problem. But ऐसा नहीं होता, पांचवा छठा केस आपके पास आएगा ही जो difficult. When you are having these difficult cases, adherence to these principles will help you a lot, and you will be doing it. If you will be not practicing all these things, and difficult cases will be difficult, and there are higher chances of conversion. So adherence of principles, I think, will show you for your safety and lesser chances. In this slide you can see cystic artery ligated first. And this is the principle. Most of the time, when you are cystic, पहले हम भी यही करते थे, cystic artery को लगाया. कई बार ऐसा होता था कि देखते ही cystic artery कहाँ है, cystic window clear किया, दोनों को एक साथ ही clip कर दिया होता है. But when you will be doing good dissection, these things will be very well visible. और cystic artery को देखा आपने, cystic artery को ligate करिए first, then cystic duct and cut cystic artery first. कई बार क्या होगा कि आपने cystic duct को जैसे हटा हल्का ट्रैक्शन लगा cystic artery, फिर इसको पकड़ नहीं पाए. 80% of the time, 20-25% है तो posterior to the. तो कुछ भी है, काहे को ब्लीडिंग करानी है, हमारे पास है चीजें, we can clip the things in before time. First clip cystic artery, then cystic duct, then cut cystic artery, and then cut cystic. These are the sequences we are using and we are seeing. You can see cystic artery ligated first, and then cystic duct, and then we are using this envelope, but this is not necessary. You can use Liga clip 300, 400, and they are पूरी दुनिया यूज कर रही है. There is no problem at all. Then removal of this gallbladder from liver. I think postgraduates are very well aware of the cystic plate, hydral plate. So we will be dissecting cystic plate, embryonic line of infusion of the gallbladder, and we are using hook and principle of hook, loop and hook. हुक के पास क्या थोड़ा पार्ट है, उसको उठाने के लिए उठाइए उसको. कार्बन डाइऑक्साइड will be your friend to dissect the things. The carbon dioxide diffusion plane will be opened up, and hook, loop, कोई ऐसा स्ट्रक्चर तो नहीं, कोई वैसा तो नहीं आपको ज़्यादा करना पड़े, ब्लेडर छोटे छोटे आते हैं, and hook उसको ज़्यादा. दिस इज द. अब यानी कि उसका लगाया शोल्डर करते चले गए, उसका कोई फायदा नहीं होता. देयर विल बी हायर चांसेस ऑफ कि गॉलब्लैडर आएगा, फट जाएगा, बिलियरी स्प्लेन. नुकसान कुछ नहीं होगा ज़्यादा, बट आपका टाइम बढ़ जाएगा, गंदा हो जाएगा. जो केस बढ़िया साफ सुथरा चल रहा था, बिलियरी स्प्लेन हुआ वहाँ पे और सब उसका खराब हो गया. देयर विल चांसेस ऑफ पोस्ट ऑपरेटिव. आपको ड्रेन रखना पड़ेगा. पर अगर आपने उठाया थोड़ा थोड़ा हुक से करते रहेंगे, एंड हुक डाइसेक्शन विल बी और ए गुड बेसिकली स्किल. बात जब आप एडवांस सर्जरी करेंगे, बहुत से लोग हैं, बहुत सर्जन हैं कि वे सारा हुक से ही डाइसेक्ट करते, अच्छी स्ट्रक्चर को. तो कोलिसिस्टेक्ट में अपने आप में एक बहुत बड़ा केस है लर्न करने के लिए, इफ यू वांट टू डू थिंग्स इन एडवांस. जब आप हुक से डाइसेक्ट करने लगेंगे मल्टीपलम को, कैलस ट्रायंगल को, तो आप बहुत सारे डिसेक्शन होंगे. जो कई बार आर्टरी का करना, लिम्फ नोड डाइसेक्शन करना था, हुक आर द गुड थिंग्स टू गो विद. तो हुक लुक एंड हुक इज द प्रिंसिपल. ये भी मैंने कहीं सुना था, आपके साथ शेयर कर. Specimen retrieval and the standard practice is in bag, but we are not having. And we can use these gloves and the surgical drains आते हैं, उनके पैकिंग होती है, उनको हम यूज कर सकते हैं इसमें डाल कर डालने के लिए ब्लेडर को. But most of the time surgeons are removing directly. But practice, if you are doing safe practice and basic thing, you have to start in learning in your training period. Start using bag, will be on your hand, and things will be done. Hemostasis. Most important hemostatic agent is surgeon. Surgeon itself is most important. को पता है कि पूजर you can put pressure, you can do these surgical or many things, but on spreader have to entertain. स्प्रेटर आपको इंश्योर करना पड़ेगा. स्प्रेटर पूरे पेशेंट को खाली कर देगा सुबह तक. स्प्रेटर को आप ऐसे नहीं छोड़ सकते. स्प्रेटर हैव टू टेक ऑल पूजर, यू कैन यूज प्रेशर, मेनी थिंग्स आर देयर, बट इफ स्प्रेटर इज देयर, दे गुड लीडर and you have to be. And most important agent is surgeon itself. Have to use your skill. Again, bipolar. Liver bed के जितने भी users हैं, most of the time they can be taken very well with bipolar. दूसरा ज़्यादा हो गया है, आप सक्शन करिए, ड्रेन स्पॉन्ज और गॉज पीस डालिए 10 मिलीमीटर वाले पोर्ट से और दोनों अपने हाथों से प्रेशर बनाइए. Put pressure for 2 minutes, 3 minutes, and then remove gauze piece by rolling. नहीं उठाइए एकदम ना, उसको डिप करिए और धीरे धीरे रोल करिए. Keep your suction in left hand and bipolar in right hand, and चाहिए धीरे धीरे उसको. The taking of hemostasis is very important. आपको कैसे करना? प्रेशर, दूसरा आपके पास है एनर्जी सोर्स में आप मोनोपोलर से कभी मत करिए. मोनोपोलर के चांसेस ऑफ स्प्रेडिंग ऑफ करंट के बहुत जाते हैं. वहाँ पर बहुत सारे डक्ट है, पोस्टर सेक्टोरल है, राइट हेपेटिक डक्ट है. आपको पता नहीं लगेगा कब इंजरी हो जाएगी, स्ट्रक्चर बन जाएगा और हो सकता है कि 5 से 7 दिन इंजरी लीक कर दे. तो बाइपोलर से आप करिए अगर आपको लिवर बेड को करना है. With the help of wet gauze piece, dry gauze piece, and with a good patience, with a good confidence. आप जैसे यदि मैं भर गया वहाँ चिल्लाना शुरू कर दिया वकी में, कोई भी काम नहीं कर पाएगा, कोई हेल्प नहीं करेगा. So don't be panic and use your skills, use your knowledge, use your experience, and things will be done. Otherwise उसी में आपको सारा कॉन्सिस्टेंट हो गया. लिवर बेड की वजह से पता लगेगा आपको ओपन करना पड़ेगा. So your patience, your skill, and your knowledge will work. Cleaning and suctioning, all BJ's stages have done, and if nothing has done, we should go for suction only. Somebody says you are infusing, you are supplementing with carbon dioxide. So if you are doing irrigation, so there are lesser chances of post-operative shoulder pain. Although I am not convinced that there is some study, but only that some carbonic acid with water and carbon dioxide, there will be lesser effect of analgesic effect of this distance and carbon dioxide. So there is no harm to this 20-25 ml saline, and you are removing it. Putting drain, you are confident enough with your surgery. There is no struggle in surgery. There is no bleeding. There is no biliary damage. So you are confident. You want to put drain or not drain, your choice. So there is no study, there is no compulsion. There is difficulty, you should put. There is no difficulty, clinical tell you not to. We are not using routinely drain. In every case we are not putting when you are having some problem, some BJD stage, a chances of infection or things. And we in government they have to be honest, because we have a long list, we are going फटाफट तो कई बार ऐसा होता है कि ट्रेन कर दो. But this is not the practice for beginners. I am accepting these things, but this must not be done in line. लंबी लिस्ट है तो उसके हिसाब से आपको करना है. But many times these things will be happening in surgery. So calculate yourself, evaluate yourself कि आपने कैसे किया है, जरूरत है नहीं है वो आपको पता लग जाता है. उसमें आपका कॉन्सेप्ट बहुत सही बताता है कि क्या करना है. गलत का पता लग जाता है. जब आप छोड़ के भाग रहे हो उधर को तब भी पता लग जाता है कि इसमें क्या करना है. तो अपने हिसाब से करते रहिए. And I think आपके और भी है, but I would like to conclude these things. Laparoscopy basically advancement of this innovation and skill, and have to be to adhere the principles of laparoscopy, putting the board in a proper way and a good learning. Because 4-5 केस आप असिस्ट करा के देख के आप नहीं कर पाएंगे. फर्स्ट सीइंग, then assisting, then doing under supervision, and then independently. Take a basically queue of 50-60 cases and you will be doing independently. So thank you very much. Thank you for your attention.
Thank you so much, sir, for beautifully describing the basics of laparoscopy. So now I would like to request Dr. Sandeep Kansa, sir, to please felicitate Dr. Dheeraj Balyan, sir.
I'm sure it will be a guide to budding surgeons to control all the principles for basic laparoscopy. I'd like to request Dr. Subharti sir to please add on.
Excellent presentation by Dr. Manjan. I have to add 2-3 points. In my experience, always put a drain डालने में अपनी घटाई ला सकते हैं, especially for the beginners. Always put a drain. Second, लैब कोली और लेप्रोस्कोपिक सर्जरी कौन कर सकता है? This is a very legal question. हमारे टाइम में हमारे कोर्स करिकुलम में नहीं था ना TOR भी था, ना लैब कोली था, ना लैब एपेंडिसेक्टमी था. तो इसलिए हमें बाद में ऑल इंडिया इंस्टीट्यूट में और आगरा मेडिकल कॉलेज में अपनी ट्रेनिंग लेनी पड़ी, जिसके कारण आज हम कर पा रहे हैं. आज के कोर्स करिकुलम में अगर पोस्ट ग्रेजुएट में ये चीज़ें हैं तब तो वो कर सकते हैं, अदरवाइज उनको कोई ना कोई MCI रिकॉग्नाइज गवर्नमेंट रिकॉग्नाइज ट्रेनिंग सेंटर से अपना सर्टिफिकेट लेना होगा. सिंपली आप किसी सोसाइटी की फेलोशिप ले लें या कॉन्फ्रेंस अटेंड कर लें या वर्कशॉप अटेंड कर लें, दैट इज नॉट लीगली परमिटेबल टू डू कोलेसिस्टेक्टमी और एपेंडिसेक्टमी. थर्डली कंसेंट लेते समय अगर आप मरीज से कहते हैं कि इसमें ये कॉम्प्लिकेशन हो जाएंगे तो आपको डर लगता है, मरीज भाग जाएगा. तो इसलिए कंसेंट लेते समय उनको वर्बली तो सब समझा दीजिए, लेकिन इन राइटिंग उससे लीजिए कि ड्यूरिंग सर्जरी एक्स्ट्रा कोई प्रोसीजर मुझे करना पड़ सकता है डिपेंडिंग अपॉन द फाइंडिंग्स एंड कॉम्प्लिकेशंस. वो कॉम्प्लिकेशन आप लिखित रूप में लेंगे तो मरीज भाग जाएगा. वो कॉम्प्लिकेशन वर्बली आप समझाइए और कंसेंट लीजिए कि मुझे लैब खोली करते समय एडिशनल प्रोसीजर करना पड़ सकता है डिपेंडिंग अपॉन फाइंडिंग्स एंड कॉम्प्लिकेशंस. फाइंडिंग्स में ओपन सर्जरी भी आ गई, फाइंडिंग में आपकी फिस्टुला भी आ गया, कॉम्प्लिकेशन में CVD इंजरी, ये सब चीज़ें आ जाएंगी. तो अगर कंसेंट में ये चीज़ें लेते हैं देन यू आर लीगली सेफ.
Thank you, sir. Thank you for adding to this subject and explaining the ethical aspects of the laparoscopic surgery. Proceeding towards the next topic. There's the saying, injury to bile duct is an accident. To miss the bile duct injury is a mistake, and to mismanage the injury is negligence. The incidence of biliary injury after laparoscopic cholecystectomy has shown a declining trend in the recent times, although it may still be twice as that of the open cholecystectomy. Major biliary or vasculobiliary injuries is associated with significant morbidity. As prevention is the best concept, the concept of a safe cholecystectomy has been recently introduced to educate surgeons and apprise them of the basic tenets of the laparoscopic cholecystectomy.
To further strengthen our knowledge on the topic of safe cholecystectomy, we call on state the panel members. Dr. B.K. Jain sir, ex-HOD and Professor Guru Tegh Bahadur Hospital, Shahadra. Dr. Nivesh Kar, Professor HOD, Kalpana Chawla Government Medical College. Dr. Anuj Sharma sir, Professor and HOD, National Capital Region Institute of Medical Science. Dr. Shashank Krishna sir, Professor Subharti Medical College. And Dr. Yashwant Rathod sir, Professor, All India Institute of Medical Science.
And our well-regarded moderator, Dr. M.K. Maheshwari sir, Professor, Head of Department, Surgery, Subharti Medical College. Please welcome sir to the meeting on the floor. Besides being an excellent surgeon, he has an impeccable clinical diagnostic skills. He is a constant inspiration and is the backbone of our department. He is an amicable and he has a very humble personality. He encouraged by example of his own discipline and commitment to his profession. Let's welcome sir on stage.
Well, today we all are here to discuss regarding the cholecystectomy and that to the safe cholecystectomy. And it is such an important surgery that most of the surgeries performed by general surgery is gallbladder surgery. So we should be well versed with the techniques and safety profile of this surgery. And that is why the whole day, today we are discussing, initially you have seen basics of laparoscopic surgery. The second panel is for safe cholecystectomy, and after it, ethical-legal aspect of bile duct injury. So whole day we are discussing the gallbladder, and it is a very, very important. It is bread and butter for the surgeon, and our young budding surgeons should be aware of this fact. We can divide this topic of safe laparoscopic cholecystectomy in 3 phases, like pre-operative preparation or before surgery, how you want to select, how you want to investigate the patient. Then basic operative technique, second phase. And lastly, but not the least, after performing surgery, what you have to look in post-operative care. When will you suspect that something has gone wrong, or whether your patient is recovering well or not. To start with this discussion, the senior most among the panel is Dr. B.K. Jain sir, मेरे भी टीचर रहे हैं सर, और I will request him, he will be talking regarding the attitude of a surgeon. And I am sure with his experience you all will be benefited, because these things are not written in a book. These things by experience, what he has learned in last 30-40 years, he will try to give you the briefing of it. So now I will request Dr. B.K. Jain sir that regarding the safe cholecystectomy, he will be presenting what he has got in his mind. Initially, like safety for whom? Yes, please, you can come, sir.
Thank you very much, Dr. Maheshwari, for your good words. I thank the organizing committee of this CME for inviting me for this talk. Now, safe cholecystectomy is a very important issue for surgeons. And when we say safe cholecystectomy, we are looking for safety of whom? Can any student say whose safety we are worried about? Anybody among our students? Whose safety we are worried about? Anybody? Yes.
Surgeon safety must.
So what I want to say, when we say safe cholecystectomy, the first thought comes in our mind that it is safety of the patient. But equally important is safety of the surgeon. So you should keep both things in mind, that what procedure or what method we should adopt that both the patient and surgeon are safe. Now, in my understanding, the most important factor in achieving a safe cholecystectomy is we or the surgeons. A competent and compassionate surgeon goes a long way in ensuring a safe cholecystectomy. You see, in course of this CME, you will find that the same concept or the same thoughts are being echoed by many speakers. So it itself tells you that how important they are. Probably Dr. Balian also said that you see surgeon's role is very important in doing a good cholecystectomy. Now, competent is good for ensuring a technically safe surgery, but compassionate surgeon is helpful in saving himself also, because he behaves with his patient nicely, he cares about them, he loves them. So there is no problem between patient and the surgeon. Now we all should strive to become a competent and compassionate surgeon. and you know that competency means right knowledge, right skill and right attitude. Now my colleagues in this CME will talk about or impart your knowledge about right knowledge and right skill. I have chosen to speak about right attitude of a surgeon. What is attitude? Attitude is a settled way of thinking and feeling about something. Attitude is a settled way of thinking or feeling about something, and our attitudes have marked influence on our performance and behavior. Now what is difficult for the teacher is that it is difficult or challenging to change attitude of a student. What is said that attitudes can be changed by role modeling. As you see your teacher doing, as you see your seniors doing, you adopt the same pattern of behavior or action. Now, in all our clinical practice, we should adopt a patient-centric approach. So that is very important. Patient first. Patient has to be center of our professional universe. All our actions and decisions should be focused on welfare of our patients. Now, if this is a patient-centric approach, so what can be the other approach? The other approach is I can do cholecystectomy with 3 ports or a single port. I can do lap chole in 20 minutes. I can do 6 to 8 operations in one session. My conversion rate is 0 to 2%. I visit 6 hospitals in a day, and in the end I am the best surgeon. So if you see, this attitude has a lack of patient-centric approach, or in this thinking process, the patient welfare find no place. Now we must think always about our patient. When you are operating, you must be aware of that the body which I am operating upon belongs to another human being, who has in good faith entrusted me to operate to cure her remedies. You must always understand that you don't have unlimited rights on the body which you are operating. You have to always do or act in welfare of the patient. We have to be always aware of our responsibility towards well-being of our patient, always and forever. Now, what are the principles of doing good to patient? There is a very known and repeatedly quoted quote that primum nocere. It means first do no harm. Whenever you are doing anything to patient, you must always in your mind must be there that whether it is going to harm patient or not. And when you doubt, you do a mom test. And mom test is for me is that when you are doing something to the patient, you think you will do same thing if this patient was having your water. So that will give you the best judgment. Now, you should be always aware what options you have. In case of intraoperative impasse, remember what options are available. If you have a difficulty during operation, you are in problem, you always think about changing the course of the operation, and which you are having always taught and told. Maybe it is fundus first gallbladder, maybe it is partial cholecystectomy, maybe it is doing a cholecystostomy and leaving it for the next cholecystectomy for the next time, or conversion to open label cholecystectomy. And if these things are not going to help you, call for help. You see, when difficulty, you must not hesitate in calling for help. It may be your senior available, even your colleague available, or even sometimes your junior available. So they may be very helpful. 2 minds are always better than 1 mind in difficult times. So you should be aware of all options and use them to do a safe cholecystectomy. Now make your own judgment. You see, if any new thought comes to you, you must make your own decision. You must not be a copycat. You see, novel versus appropriate. You see, everything, new things are happening in this world. New papers are published, new things are being reported. But we must all understand that while you are reporting a new thing, the most interest is to highlight yourself. So it is up to the audience or the readers. They should decide for themselves how appropriate is it. You see, nowadays there is time for transluminal laparoscopic surgery. So in a conference I heard that in India we are pioneer, that we have reported 50 transvaginal laparoscopic cholecystectomy. So you apply your own mind whether you will like to do this, whether a patient should accept this or not. So nowadays there is what is becoming vogue is transoral thyroidectomy. So I don't want to criticize, but what you want to say, for every new thing you think it is noble, it is appropriate. So you make your own. If you want to go with the way, go with it. But we stop and apply your mind. Now another thing is very important. Is temporary post-operative pain and post-operative scar is the most forbidden thing in this world? That also you have to decide. You see, if I have to undergo a inguinal hernia repair for myself today, I will choose open hernioplasty. So that is my viewpoint. I have thought about the thing and decided for myself. So I say you should always think over issues and decide for yourself. Do not be a copycat. Do not follow without applying your mind. Abide by your technique. Learning a procedure when and adhering to it is good. Every day jumping to a new technique may affect the quality of your life. Do not be a copycat. Consider your area of interest, profile of your patient, your workload before deciding to adopt a new technique. You see, what I am conveying here is my opinion. It is not a sermon. It is food for thought. You should think over it. Whether you like it, accept it, it's all right. If you don't like it, it is all right. Now, surgeon has a leadership role also. You must help and lead your patient in making the right choice of treatment. Nowadays, every patient, whoever comes for any surgery, will ask, "Doctor, आप लेजर से होगा ना मेरा ऑपरेशन?" समझे? So you have to educate them and tell them what is necessary, what is good. That is very important, and you have to explain that, you see, laser is an energy source. What we are using as a monopolar, bipolar cautery is also energy source. So there are areas where laser has distinct advantage, but at several places it has no advantage or at least cost effectiveness. So that you have to explain. No scope for complacency. Cholecystectomy is a frequent operation. But remember that every patient is different from the other patient. You see, I have always heard in theatre, क्या है भाई, रोज ही लेप्रोस्कोपी करते हैं, रोज ही कोलेस्टेक्टमी करते हैं, हम तो बोर हो गए. So you see, what is very important is, I am working at a place where truncal vagotomy and gastrojejunoscopy were the most common operation. When I did my post-graduation from LLR Medical College, the first surgery which a PG used to get is suprapubic cystoscopy. That means it was very common because whenever a catheter will not go in a large prostate, will under local anesthesia do a suprapubic cystoscopy. So I want in Pondicherry, so their first surgery which a PG gets to get is gastrojejunoscopy, because there were so many truncal vagotomy. So when their residents are doing this operation, you see, the junior most will do gastrojejunoscopy. The next senior will do truncal vagotomy. So unke liye it was a matter of prestige that I have learned gastrojejunoscopy. Now I need not do it. So I will do vagotomy and gastrojejunoscopy somebody is doing it. So it means their thought was that once you have learned a procedure, you need not do it. I think other way around, that you learn a procedure well and then you do this procedure for your patient. So that is very important. That no operation is simple and there is no scope for casualness or complexity. And my experience tells me that common bile duct injury has occurred more often in a simple and straightforward gallbladder than in difficult. I have been called to see patients whom intraoperatively CVT injury has occurred. You ask surgeon what has happened? Nothing, sir. It was a normal simple gallbladder. You ask assistant what has happened? Nothing, sir. It was simple gallbladder. So that is very interesting that most of the injury occur in simple gallbladder. And probably what the reason I have understand that almost a virgin field, you put extra traction on the gallbladder and you pull the common bile duct toward you, and instead of dissecting cystic duct, you dissect common bile duct like 25. Now that was about what things may be important in forming a good attitude for a surgeon. Now I will talk about pre-operative assessment. I will be brief and not exhaustive. If you think I have missed something, we can bring it during discussions. Now I will discuss in two heads: the assessment for disease pathology and overall assessment of the patient. Now we do laparoscopic cholecystectomy mainly for gallstone disease, gallbladder polyp, acalculous cholecystitis and gallbladder perforation. So this constitutes majority of the cases of laparoscopic cholecystectomy. Now when we are examining or evaluating patient, we must look for conditions which may complicate the operation of cholecystectomy, laparoscopic cholecystectomy. What are those conditions? The first four are which improves the challenge during laparoscopic cholecystectomy. If you are having a patient of acute cholecystitis, acute or empyema of the gallbladder, you may have this difficulty because everything will be swollen, friable. You may have difficulty in holding the organ or dissecting. Portal hypertension, you know that there may be a portal cavernoma which will make operation very bloody. And if you are not prepared and skillful, it may lead to a disaster. And xanthochromatosis cholecystitis is a condition which mimics malignancy very much. And it makes the operation difficult because there are a lot of reasons. Probably the only thing which you can discuss, differentiate intraoperatively from malignancy is the absence of enlarged lymph nodes. So you must be aware of this condition. And previous surgery in upper abdomen. So it is always better if you can know these things beforehand or keep them in mind when you are mentally preparing for a surgery. It will be helpful to do a good job. Now CBD stone, all of us know, has treatment available which if you find out CBD stone pre-operatively, you can handle them by endoscopic removal or stenting. Now carcinoma gallbladder is not a condition which should be prima facie handled by laparoscopy. So if you can diagnose that there is a possibility of carcinoma gallbladder, it is better to approach it differently. Now how we can identify these conditions? I say physical focal examination for a gallbladder case. You look for jaundice. You look for lymph nodes in the neck. You look in abdomen for muscle guard and tenderness, which shows that probably acute pathology is there. And you look for a gallbladder lump. If carefully palpate and look for gallbladder lump. If gallbladder lump, the possibility of empyema, acute cholecystitis, malignancy, all these things proper. And scar of Injure. And what is very important to examine these things, sometimes what happens, you work up a patient in OPD and in our hospital he gets date for operation after 4 months. So it is very important that a patient who is admitted for operation, he should be de novo assessed again because his condition could have been changed between these times. Now what investigations are available for us is liver function test, gamma glutathione transferase. This is basically to identify how is the liver function, whether there is possibility of CVD stone or not. Sometimes your patient is continuous pain, gallbladder stone pain, you have to look for if there is any sort of pancreatitis is there. Then ultrasound is mainstay of a diagnosis of gallstone disease. And in next slide I will discuss what are the important things you have to look for in the. You have to be very careful when you are seeing the ultrasound report, because patient may get ultrasound done from anywhere, and there are several places where a beautiful letterhead is there, but the name of ultrasonologist, his degrees are not written, you do not know how to rely on those reports. So you have to check for these things. Who has reported, what is his qualification. And then MRC and CT are other investigations which are required in special circumstances. If you have suspected jaundice or you want to study biliary duct structure, you may ask for MRCP. Or if you are suspecting a malignancy, you may ask CT abdomen. Now in ultrasound report, you have to see things carefully. How the presence of gallstones have been reported. Because sometimes what happens that the report is not clear, they do not say that multiple gallstones are present, ecogenic structures are present. I have seen many times they say some ecogenicity in gallbladder fossa. I have ended up in 4 cases of agenesis of gallbladder reported like this. So there is a sentence WES that says wall shadow qualification for ultrasonic diagnosis of gallstone. So you will be very sure how they have described presence of a gallbladder. Then you should look for how is the gallbladder thickness. We know that gallbladder thickness is become thickened in acute cholecystitis, chronic cholecystitis, also in carcinoma. But usually in carcinoma, it is uneven thickening of a particular part of the gallbladder, and there is an adjoining liver is infiltrated. So you have to carefully see whether these things have been nicely mentioned or not. Then liver you see for intrahepatic biliary dilatation and for any mass lesion in the liver. Again, bile duct you see whether the common bile duct has been described or not, whether it is enlarged or not, whether there is the evidence of stone there or not. And of course, you look for lymph node and free fluid in case you are suspecting for malignancy. So you have to very carefully see the ultrasound report for yourself. If you are not happy with the report, you can ask a repeat ultrasound. Now that was assessment of disease pathology. Then we will do an overall assessment of the patient for fitness for surgery and anesthesia. So you look whether there is any comorbidity, diabetes, hypertension, cardiopulmonary disease, breathing disorder, viral infections like HIV, hepatitis B, C, now COVID, and if any other thing is specific. And you have not only to list these comorbidities, you have to see that before operation they have been optimized. Patient has received optimum treatment for these conditions. And I have added this that you should make a habit of becoming aware of the psychosocial profile of your patient and his fitness. If you try, you can identify some very few people who are likely to make mistakes. So if your attention is toward this, you will be better care for yourself. Now I strongly recommend that as there is a PSC is done pre-anesthetic stuff, make a policy that for your all operative patient, a pre-surgery assessment record or checklist should be filled up by your surgical resident or colleague. And what it should see, whether the diagnosis is sustainable or not. A ultrasound is there or not, whether it is adequate means all those things which I have mentioned, it has been reported or not. Is it reliable or not, it has been done by a reliable person or not. If patient has any complicated factor, you notice obesity is there, jaundice is there, lump is there, and it requires any special investigation that is there or not. What are the comorbidities and they have been optimized or not. If patient has a special requirement in theatre, whether those things are available or not, and if any special consent is required, that has been taken. And I will like to make a comment on what has been said by my previous speaker, and then there was a comment. My personal view is that all complications should be specifically mentioned to the patient by name. And if you want to lighten the burden of that complication on patient, you can say in a few patients this can be. There is no relief if you say the only complication has been mentioned or complication treatment will be done. I like to tell my patients what complications are likely to happen. But when you are telling them, you can be downplay that or complication occur naturally in a small number of patients. But mentioning all complications specifically is important. Now, I end by revising the message what is there. Surgeon is cornerstone of safe cholecystectomy. Patient welfare remains the most important concern in our life, professional life. Through thorough pre-operative assessment contributes a lot to safe cholecystectomy. Thank you.
Thank you very much, sir. In a brief presentation, you have emphasized what is the need of the hour. Today, what I see, when I was a student, we were seeing open cholecystectomy. But these days, our PGs, they are looking only for laparoscopic cholecystectomy. And out of 10, 9 cases are left cholecystectomy. But in my opinion, and what Dr. Udwadia from Bombay, he says we should attempt laparoscopic cholecystectomy only when you have assisted 50 open cholecystectomy. You should be well versed with the technique and procedure of cholecystectomy first. So we have got other people in the panel who will be talking and they will be telling about their experiences regarding what to be done just before the surgery and during the surgery, what precautions you should take. But in my opinion, all of you should, whenever you have got an opportunity, please assist in open cholecystectomy as well. Because most of the young people, they don't know how to do open cholecystectomy. Because if complication arises, you should be prepared to deal with it. Now, before the surgery, as pre-operative part, sir has very well covered. Now, how to select a patient for cholecystectomy in the pre-operative phase? Most of the things have been covered, but there are few contraindications like unable to tolerate general anesthesia, because most of the time general anesthesia is required for lap cholecystectomy. We are talking keeping the laparoscopic cholecystectomy in mind. The discussion will be on lap chole. Refractory coagulopathy, suspicion of carcinoma, if it is there, these are the contraindications. Then relatively there is, if a patient is having chronic obstructive pulmonary disease or there is a cholecystoitis fistula, morbid obesity and pregnancy. Then previous upper abdominal surgery, if patient is giving history or on examination you find that patient is having cholangitis, diffuse peritonitis, cirrhosis or portal hypertension, as sir has already said that in portal hypertension there will be possibility of much bleeding in the liver area. Now, let us start with pre-operative preparation. I will start with Dr. Nivesh is here. He will be telling regarding the pre-operative preparation for the patient. So this is the first one. As all of you know, antibiotic should be given or not to be given. What is your opinion, sir?
As per studies, it has been seen that in the normal gallbladder cases with having the no comorbidities, single shot of antibiotic is sufficient. But if patient has comorbidities, patient is having the complication like fistulas, like any acute cholestasis or any other having the cholangitis, then prolonged cover of antibiotic is required.
So I think message is clear. If surgery is lasting more than 4 hours, you have to repeat the shot. If within 2 hours, single shot is good enough. Now what about the deep venous thrombosis prophylaxis, sir? Dr. Nivesh.
There is a chances of deep venous thrombosis when cholecystectomy has been prolonged for the longer time, because there is a pneumoperitoneum, then there is reverse tenderable position, and there is due to the general anesthesia there is vasodilatation, which they all can lead to the deep venous thrombosis. So as per any other surgery of the abdomen and the lower limbs, we have to give the proper DVT prophylaxis, because this is a dreaded condition, and if it occurs, then can lead to the lifelong complication for the patient. So we have to get the pneumatic cuffs on the patient's limb and give the all prophylaxis for the DVT. And if in the normal cases, and if patient has already having some coagulopathy and some issues, then accordingly patient has to be given anticoagulants like low molecular heparins, etc. Not for the aspirin and all, because they will impart with the operation. But this has to be given, and accordingly INR ratio has to be maintained, and accordingly patient has to be operated.
So this is regarding in patient with additional risk factors, previous DVT history is there, possibility of cancer. All of you know that in presence of cancer, migrating thrombophlebitis may occur. Obesity is another factor, exogenous estrogen, if they have gained this DVT. Now, biochemical and radiological investigation to see the alkaline phosphatase and diameter of the CVD, already sir has covered, so I will not like to repeat it. Sir has already asked regarding because alkaline phosphatase is a must before you undergo lab cholecystectomy, because if it is increased, you suspect something is blocking the CVD. Now, if we talk regarding what precaution or what thing we should observe so that we can play a safe cholecystectomy. So during surgery, what factors are there which is helpful in ergonomics in performing a safe cholecystectomy? And I will request Dr. Shashank Mishra. He is very energetic in explaining these techniques. So basic operative technique, room setup and patient positioning, we will be talking regarding it.
Thank you, sir. Am I audible? Last row? Yes? Am I audible? Yes. Most of the thing in basic laparoscopy very well covered by sir. Few of the things were I would like to add here. Whenever we are operating any patient for a gallbladder stone disease, few basic principles are: follow the principle of coaxial alignment as far as the positioning is concerned. The surgeon's position as per the patient and the target organ. So one principle is coaxial alignment. The surgeon's eyes, the target organ and the monitor. All these three should be in a straight line. Surgeon should stand contralaterally, opposite to the side of target organ. Let's say if somebody is operating the gallbladder, and normally gallbladder is in the right hypochondrium, the surgeon should stand on the left side of the patient. And regarding the other ergonomic principle, the OT table height. OT table height should be 0.49 multiplied by the height of the surgeon. So we can always calculate according to us what is the ideal OT table height for a particular surgeon. Suppose somebody's height is 100 centimeter, so OT table height for that particular surgeon will be 49 centimeter. Other than this, obviously there are a few techniques, the French technique and American technique. In French technique, the surgeons standing between the legs, and in American, usually we are practicing here, we are standing on the left side of patient whenever we are operating a gallbladder. Whenever we are going to compare this laparoscopic surgery with open surgery, there is basic difference. In open surgery, assistant is there, other people are there who can assist you. But in laparoscopic surgery, if you have placed the port, means now you are having fixed entry and exit inside the abdomen. You cannot change that. So for that, placing a good port, baseball diamond concept is there. Baseball diamond concept is, as you can see in this diagram, first decide your target. Now, safe cholecystectomy, our target is, let's say, Kellogg's triangle. So to target the second, where second is written, that is target. So if I can show like this, where my index finger, both index finger, they are meeting. This is the point for target, and where my thumb, they are meeting. This is the position or port for telescope, laparoscope. And both the anatomical snuff box, both the sides, these are for two working ports, left and right. The idea is, between any two ports, we must have distance between any two ports, it should be more than 7.5 centimeter and not more than 10 centimeter. Means anything between 7.5 centimeter to 10 centimeter. And why this is so? This is because if we are putting these ports, taking care of this distance, we are bound to have manipulation angle of 60 degree. And this is the best manipulation angle with the help of which we can perform any type of surgery in laparoscopy. Another important point in ergonomic is, there are three angles: the elevation angle, the azimuth angle, and manipulation angle. Manipulation angle means the angle formed by the two working ports, the two working instruments at the target site. The elevation angle, am I audible? Last two, yes? Now elevation angle is the angle between the instrument and the body of the patient, elevation angle. And azimuth angle means the angle between a working instrument and laparoscope or telescope. So ideally, the manipulation angle should be as near as possible. It should be 60 degree. Even sir is sitting like this, both the hands they are making 60 degree angle. Naturally, the 60 degree angle is comfortable for all of us. So while performing any laparoscopic surgery, manipulation angle should be 60 degree. Then elevation angle is it should be between 30 to 60 degree. And azimuth angle 30 degree ideally, but yes, plus minus 15 degree means 15 to 45 degree. And why these degrees are important? The last sentence then I will regarding the ergonomic. For better performance in any laparoscopic surgery, all the instruments, as Dheeraj sir in the previous lecture rightly said, we must have all the instruments working as type 1 level in physics. There are 3 types of working: type 1, type 2 and type 3. In laparoscopic, our effort should be that we must use any instrument as type 1 level. Type 1 level means half of the instrument length should be inside the abdomen and half of the instrument should lie outside the abdomen while manipulating any organ. Similarly, if we are going towards elevation angle more than 60 degree towards 90, means we are converting these instruments to type 2 level. मीन्स आप उसको क्या करेंगे, बाहर ज्यादा मूवमेंट होगा, अंदर वो थोड़ा सा मूवमेंट करेगा. एंड ऑन द अदर हैंड इफ यू आर यूजिंग दैट विद टाइप 3 means there will be overshooting. More than half of the instruments are lying inside the peritoneal cavity and less of the instrument left is outside. You will move less, but there will be larger movement inside, so that may lead to complications. So we should consider all these factors. There are so many, but these are the important ones.
So these are the small points, but they are important. If you do according what he has told, it will be easier for you to perform a surgery. Now I will request Dr. Yashwant Rathore to please enumerate various ways of gaining access to the intra-abdominal area for laparoscopic cholecystectomy.
So everything and a lot of things has been covered by Dr. Dheeraj, Dr. Jain in detail. Just want to tell two more things about the ergonomics. One is the down gaze while operating, and one is the distance from the screen distance or the console distance from the OT top. So this is supposed to be 5 times of the diagonal length of the your screen. And this is different for the 4K techniques and for the HD techniques. So now I'm talking about the abdominal access. So everybody knows about the varus needle. This is like the line technique. Have to be little careful while inserting the varus needle. And this is supposed not to go vertically. This is supposed to be little horizontal, 45 degree towards the pelvis, towards the urinary bladder. Always check the patency. Easy access, whether aspirated, the varus needle is in the proper position or not by the needle aspiration, and inject little saline going through or not. One. Second is the open Hassan technique. This is important while the patient having the umbilical hernias. One, and with the multiple attempts like the 2 or 3, and you are unable to insert the varus needle. So the second technique is the open Hassan technique. Has to be little careful that time. One is the direct trocar or the optical trocar under vision. For this thing we need axial trocars and the 0 degree telescope, and go vertically down and see the layer by layer and enter in the abdominal cavity. Don't pressure too much to avoid any injury, abdominal organ injuries. So the other few things have to be little careful while entering in the abdomen. Avoid any sharp trocars. Now there are a lot of safety techniques available for the trocars. Previously we have the steel trocars and metallic trocars with the vivae lace. So we have the blunt trocars, so use them carefully and check your instrument nicely. So adequate choice. If the patient is average weight, not very obese patient, so 30 to 35 centimeter of the adequate length of the instrument is quite good enough. If the patient is obese, so we can use the long instrument, like 45 centimeter of the instrument can be used, and the trocar of 15 centimeter or the long length is needed to tackle the situation, difficult situation. So about the energy devices, already some side has been covered. There's no much difference about the monopolar versus bipolar versus the harmonic. Always use your energy devices nicely. And I think every surgeon is using the monopolar. The setting is very important. Use the 30 watt in the generator. Don't use much. One. Second, use the intermittent burst by using the monopolar throttle. It's not like the running. Supposed to be used intermittently in the pulsatile way. The pulse supposed to be used like for the 2 or 3 seconds. It's not like continuous 5, 6 seconds you are using the monopolar. And use and dissect it properly. This is the important thing. About the harmonic, once you have the difficulties, like there are a lot of additions, momental additions are present, gallbladder wall is thick, and you are thinking the monopolar will not work. In that condition, you can use the harmonic, but otherwise, monopolar is good enough to dissect everything from starting to the end. The low pressure versus standard pressure, though the standard pressure is sufficient enough for the taking the or doing the laparoscopic cholecystectomy, low pressure can be used where the patient like develop the bradycardia. So that thing has to be taken care nicely while injecting the virus needle or insufflation. So always see the anesthetist monitor whether there is some bradycardia or not. So that thing, this is the surgeon's responsibility to see the bradycardia. And in these conditions, the one is the patient develop the bradycardia. Second is the patient having the mild to moderate degree of the COPD. In these conditions, we can use the low pressure for the cholecystectomy.
Now, you want to say something? Yes.
As far as the intra-abdominal pressure is concerned, for PGs, whenever we are operating any patient and the intra-abdominal pressure is, we are keeping it less than or at 8 millimeter of mercury, there is no cardiovascular derangement in the patient. And if you are going to increase it by 4, means 12 millimeter of mercury, there is 20%, roughly 20% reduction in venous return. And if we are going to increase it up to 15, which we are normally doing, we are operating all the patients between 14 to 15. There is roughly 40% reduction in venous return. So for the take-home message is, above 18, never have any intra-abdominal pressure during any laparoscopic surgery. Above 18, don't go beyond that. Best is around 15 or less than 15. Thank you.
So with this, after assessing the abdominal cavity for laparoscopic, let us discuss those factors which can put you in trouble. So now I will request Dr. Nivesh to please highlight those anatomical or you can say pathological condition which can do more harm if you are not careful about it.
When for the safe cholecystectomy, identification of the callus triangle and the structures are very important. Mainly, we have to ligate the two things, that is the cystic duct and the cystic artery. So, basic concept is we have to critical view of safety should be there, and only two structures should be passing from the middle side to the gallbladder. Only then we have to ligate. But normally, what happens in the 80 to 90% cases there are no issues, but in some cases there may be anatomical variation. Anatomical variation may be due to the cystic duct, which may be short, which may be very long, which may be going arising from the posterior to the vessel, and other anomalies can be there. So until and unless these all have been callus triangle has properly dissected and these cystic duct and artery are being visualized, only then they have to be ligated. Then before ligation, it is important to have a timeout time. You have dissected, then call for timeout, ask your assistant, ask your other that now these are two structures and we are going to ligate. Then only you have to ligate it, because once it has been clipped and ligated, then it is not reversible. So it is only the point then where you can reverse it. So you have to wait, you have to go timeout. Then you have to, because once it has been done, then it is the morbidity and mortality for the patient increases many times. So that is the only opportunity when you have clipped and cut. Before that you have to stop and you have to reassess your anatomy. Similarly, for the cystic artery, you have to check for the lymph node. It is along with the lymph node, it is best, but it may be what happens, there may be caterpillar loop of the right hepatic artery. Artery may be going posterior. There may be two artery, anterior and posterior arteries. Cystic artery may be there. So artery, cystic artery may be rising from the left hepatic artery, maybe from the pancreatoduodenal artery. So there may be many variations. So you have to identify, then only you have to ligate, because once this vessel is being avulsed and it started bleeding, then as Dr. Dhiri already said, that there is lot of complications to control that bleeding. And sometimes simple for this reason that it has been avulsed, you have to convert it to an open. So precaution is better than cure, as you all know. So we have to be very meticulous while dealing with the callus triangle, while we have to ligating the cystic duct and the cystic artery, because our maximum complication is arising only in this area. Once this has been over, then rest of the surgery can proceed easily. So normal anatomy is there, average anatomy is there. Only cure is you have to do the posterior dissection, you have to do the anterior dissection, you have to proper critical view of safety should be there. You have to stop before ligating the cystic duct and artery, and you have to identify, and then only you have to ligate.
So it is very important that anterior view and posterior view while dissecting the gallbladder should be taken, so that you can identify the vessel and duct nicely.
So also it is known as Ganesha sign, because you have to ligate, you have to dissect the cystic duct, cystic artery, and somewhat gallbladder has to be dissected from the liver bed, lower part of liver bed. So it makes the Ganesha sign. Only when it is visible, then only we have to ligate it.
So this hepatocystic triangle is very important, in which you have to make a dissection and you have to separate the artery and duct nicely.
May I say something?
This is
One thing I want to say that most frequent anomaly which I have faced is what we say is a caterpillar hump of right hepatic artery. So when you are anytime dissecting for a cystic artery, if you see or feel that this cystic artery is quite large, more than expected, you should dissect it more distally towards gallbladder. And ultimately you will find that a fine branch of cystic artery is arising very close to the gallbladder, and then this right hepatic duct is returning back to the porta. So that is a clue how to identify a caterpillar right hepatic artery.
very
Thank you.
So this is regarding diagrammatic representation of hepatocystic triangle and the Caillet triangle within it. Now I will request Dr. Anuj, will you please specify what is subtotal cholecystectomy and when we should do it?
Before coming to so much theory, I will just go out of the league if you permit me. There are three godfathers in this room. Sir is the first godfather who has taught me the open surgery, and Rathi sir and Dheeraj sir are sitting there who have taught me a laparoscopic surgery. So that's what I wanted to say. Other things, everyone knows what is anatomy, what are the complications, how you can do it. The most important thing, you should know how much you can do, and always ask for help in initial time. I used to say, sir, मुझे लैब को नहीं लगानी है, please आप आ जाओ. मतलब there is no shame. When I joined TTV, I had no exposure. Sir told gastrointestinal is done by second year. That's true, but मैंने नहीं किया था. And I still remember Dr. Indu Dubey, he was my JR too. He taught me how to do gastrointestinal, and I still call him Guruji. I'm telling you, there should be no shame in learning from your juniors. You should be always ready and always happy. I had no exposure of laparoscopic surgery when I joined LLR in medical college. And just because of my mentors, I learned it. And I'll tell you this thing, this is only between Dr. Dheeraj and me. No one knows it. but I can tell you what all complication a person can face. So after becoming quite good, there was a patient known to Dheeraj sir and he was not available. And he told कि भाई अगर तुम्हें आज ही कराना है तो मैं डॉक्टर अनुज को बोल देता हूँ. So it was a proud thing for any junior कि भाई उनको बोल रहे हैं कि अगर मैं नहीं हूँ तो तुम कर लेना. And what happened in this case, I'll tell you. We had a blunt trogar which can be opened from the tip. सर कह रहे हैं मत बताओ, but पता लगना चाहिए आपको कॉम्प्लिकेशन यही नहीं होती जो बुक्स में लिखी हुई है. You can face any time complication. So blunt trogar था, umbilical cord से डाला and did the cholecystectomy wonderfully, no problem. Close the abdomen. Sister told कि सर उसका टिप नहीं दिख रहा है. मैंने कहा यार टिप नहीं दिख रहा है क्या मतलब है, तुमने कहीं रख दिया होगा. मतलब it was a blunt trogar, this much big. बट वो सेंटर से खुलता था, ऐसा कभी देखा नहीं मैंने, बट वो सेंटर से खुलता था. कि उसका टिप नहीं दिख रहा है, पूरा टिप, दिस मच बिग टिप. तो मैंने कहा सिस्टर आपने कहीं रख दिया होगा, छोड़ो. एंड एवरीथिंग वेंट ऑन. आई टोल्ड दिस थिंग टू सर कि सर पता नहीं उन्होंने कहाँ खो दिया. ही सेड खो दिया होगा यार, कोई बात. आफ्टर व्हेन पेशेंट केम फॉर सूचर रिमूवल, सर के दिमाग में आया, सर ने कहा इसका एक्सरे कराया. एक्सरे कराया तो उसमें पूरा का पूरा ट्रोकार पड़ा था. So, but just see the attitude. सर सेट की एक्सरे जिसने किया उसने बताया, सर ने कहा एक्सरे मेरे पास भेज दो. He kept the X-ray. He told patient कि there is some slip of the clip or something and we have to do a small thing. We will put the clip again. And patient was done the same day without any hep shave और कुछ भी हो सकता था. मतलब it is a big thing कि आप इतना बड़ा वो छोड़ दो. तो that's what I am saying कि आपको ये बहुत देखना है कि अपने colleagues को, अपने juniors को, अपने seniors को सबको protect करना है. बट यहाँ होता नहीं है, स्पेशली प्राइवेट प्रैक्टिस में तो बहुत ही ज्यादा खराब हाल है इस मामले में लेके. तो ये चीजें जो हमने सीखी है, these things are very important. बाकी सब complications, just know what is your limit. Even after 10 years, 15 years, I know कि if I am doing this surgery, I need help. But otherwise, the attitude is fully different. So now, coming back to the theory. So, frankly, I haven't done any partial cholecystectomy and have no exposure for it, especially laparoscopic. If anyone of you have done, sir?
Yes, Dr. Sachan, you please.
As far as the laparoscopic subtotal cholecystectomy is concerned, usually there are three types of LSC: type 1, type 2 and type 3. Very simply, whenever the Kellogg's triangle is difficult to dissect, you cannot progress for dissection inside Kellogg's triangle, you cannot identify the cystic duct, cystic artery, then the choice is LSC type 2. Whenever there is difficult gallbladder bed, that cystic plate, the posterior wall is very much adherent or intrahepatic, then type 1 LSC is done. When both the Kellogg's triangle as well as gallbladder bed is difficult to manage, then sometimes yes, LSC type 3 can be done, and in that we are leaving that Kellogg's triangle behind as well as the posterior part of gallbladder. The dissection is the submucosal plate.
To add a few more points, this is the bailout techniques where the Kellogg's is frozen, and you are unable to dissect cystic duct and cystic artery. So in this condition, the one is the fundus first one. Second, even after that you are unable to proceed further, you can open the gallbladder above, you can remove the stone completely, check the patency. If there is no stone, then stuff can be taken either by the stapler, if you can dissect the posterior and the anterior part nicely. You are not knowing the suturing. So one is the suturing standard, you can close the stump properly. Second is the stapler, you can fire the stapler, close the stump nicely. And one more is the loop, and loops are also available. So these are the bailout techniques. And one, if you are not well versed with the laparoscopic these things, so the conversion is always available. So So convert to open and take out the things nicely. This is the important thing. So always know about your bailout techniques in the frozen canals condition.
What about use of partial cooling? If I still not satisfied with it. I have
Partial-
operated 2 cases which were done partial cholecystectomy and we operated for completion.
It means you want to avoid the CBD injuries where the anatomy is not clear.
That
near
is
the
just like
CBD.
diversion.
Yeah.
You should go for complete cholecystectomy when other things get settled.
So complete when
I think in our time also, the basic teaching was, if you are finding it difficult, apart from subtotal, the other procedure which was there, and I have done in 1 or 2 cases in my entire career till now. We put a police catheter in the gallbladder, and at a later date, that means we are doing cholecystostomy, and after doing this patency, whether the CBD is clear or not, 6 weeks later, when inflammation has subsided and things are better, you can perform cholecystectomy. It is better to play a safe game rather than injuring the CBD. हमारे टीचर डॉक्टर नाजर कहा करते थे, it is better to have one incision rather than multiple incision of the abdomen, because if you create a complication in CBD injury, so many surgery may be required to save the life. So it is better. There is no harm putting a tube, but rare. Only in my entire career of 30 years, I have in 1 or 2 patients I have put the tube, and 6 weeks later we have done the cholecystectomy.
Basically, concept of subtotal cholecystectomy, we are going to, anyhow we are going to remove the gallbladder mucosa. We are dissecting through the submucosal plate. We are just leaving behind the outer wall of the gallbladder. That is very much adherent to the liver, gallbladder bed. In type 1 laparoscopic subtotal cholecystectomy. In type 2, we are leaving behind the Hartmann's pouch, the Calot's triangle, the thickened part, the outer wall, and the remaining gallbladder mucosa we are going to burn with bipolar pottery, and then just endo suture it, put a drain, come out. All the stones are going to be removed anyhow, and I think if we can prevent bile injury by doing this, should be done.
Sir, please.
You see, I have experience of doing partial cholecystectomy during open cholecystectomies. I will say it is a very precious procedure and everybody should know it and do it whenever required. Practically you see when you do a partial cholecystectomy and divide the gallbladder, what is left is a very small rim of gallbladder proximally beyond the cystic duct opening. It will be half centimeter or 1 centimeter.
Right.
What you have to make sure that the stones from the cystic duct have been removed. That is necessary. So you must make some exerts to make sure that the duct is patent, and it will be known if bile flows back. If it does not flow back, gently you can put a probe or bile duct dilator of appropriate size gently in the common bile duct and feed it stick in the common bile duct. That can be done. And then you can fulgurate the mucosa of the remaining gallbladder and then stitch it with interrupted suture, vitreous sutures. So you are always away from the cystic duct and Gallup triangle, and there is no need to do a second procedure after.
Sir, I want to add, what happens, there are 2 conditions. First condition is when callets are very frozen, and second is when gallbladder is deep, posterior border wall is deep in the liver. So it can cause a liver injury. In these 2 conditions, mainly we used to do the partial cholecystectomy. So in when gallbladder is very deep in the liver and we do the remove the whole gallbladder, leaving the posterior wall and we do removing the mucosa, there are no issues. But what happens when callet is frozen? There may be 2 conditions. Either it may be due to the chronic infection or it may be due to the some malignancy. So in the laparoscopic cholecystectomy, partial, where we are doing the partial cholecystectomy, then it is better to have the hand assisted complete the cholecystectomy. If not possible, then go for the open cholecystectomy, because doing the laparoscopic partial cholecystectomy is not worth, because once we are going taking for the patient for the surgery, better to complete the cholecystectomy. If we are not going able to do by the hand assisted, then complete it by the open cholecystectomy.
What do you mean by hand assisted?
means कि suppose you can enlarge a port, you put your hand or the two fingers, you can have the tactile sensation and having the advantage of both the open as well as the laparoscopic cholecystectomy, laparoscopy. So if with that you can do the dissection with the hands and then you can complete the cholecystectomy. But if it's not possible, it is still adhered, then you go for the open cholecystectomy. But laparoscopic cholecystectomy partial is not the work of doing it, because once you're taking the patient for the cholecystectomy, it has to be completed. But in open sometimes also, as sir has said, there are conditions, the patients are there where they frozen callus we can't dissect, then it is we can go for the partial cholecystectomy, and with that, like sir has said, that we can fulgurate the mucosa, close it completely, and so that there is no chance of piling, even no chance of recurrence of the LSO. Then it can work. But in my opinion, laparoscopic partial cholecystectomy has no role.
Anything, Dr. Sanjay Pandey, you want to add regarding this, because you have got a vast experience? Might provide the
Some of the portion can be left behind, but yes, mucosa has to be fulgurated. Part of the technique, but confirm, yes, no stones are there. But sir, you have given very nicely the fact, and everybody is saying yes, it can be completed by an open procedure. But the problem is most of our postgraduates, they have no exposure of open surgery. They have not dealt with open surgeries. They are only exposed to such surgeries once or twice or thrice a year. That is the problem. Then what to do? Because it's very easy for me to say yes, I'll convert and I'll deal with it. But for them, it is really a difficult task. What should they do? Number one. Number two, one thing we have not discussed appropriately, I think, say, yes, partial cholecystectomy is a way out. It's an important way out. It can be done laparoscopically, it can be done by open technique. But sir, what to do with our so-called maxillary duct, a double cystic duct, a polycystic duct, or a sectoral duct? How to identify that duct during my dissection, and what is the appropriate method to use with it? I may be dissecting or dividing or ligating a common body. What to do? I just want to ask the August panelist about it.
Dr. Rathore, would you like to answer his question?
Again, sir, your point, one is in the difficult conditions, the partial cholecystectomy, either the open or the laparoscopic, is depending upon the surgeon's expertise. Now the question about how to identify the anatomy intraoperatively. But if you can dissect properly, that is fine. In the conditions like the difficult situations, so identification is either by the intra-op cholangiogram. One, second is the intra-op ultrasound. The problem with the intra-op cholangiogram is if you know how to read the cholangiogram, how to do it properly, that is fine. If day in, day out we are using this technique, intra-op cholangiogram, that is okay. The surgeon will be okay, comfortable, yes, I can read the X-ray, yes, this is the like the one duct, other duct, that is fine. So in my opinion, yes, the intra-op cholangiogram can be done, but the more commonly used is the intra-op ultrasound. So the radiologist will tell you, yes, this is the anatomy and this is your dissection little away from the dangerous areas. So they are the like two things we can use intraoperatively.
Another thing I would like to add to this. Whenever you are in doubt whether we are going to injure the CVD or not, the first important trick is always try to be nearer to the gallbladder. If in doubt, there are three principles of that critical view of safety, and one of them is always dissect the lower 1/3 of gallbladder. Try to be nearer to the gallbladder, and if possible, if you know the endoknotic, always prefer endoknoting nearer to the gallbladder if the wide cystic duct is there. If still in doubt, just roughly 1 centimeter proximal to that cystic duct joining the gallbladder, cut it and you can directly go, if you are having a 5 mm telescope, you can directly go and visualize the opening of the cystic duct, whether there are 2 openings or a single opening.
Later we have covered that. Please simultaneously explain the significance of knowing the Rubius circle. What is the significance of it?
So it has been seen that we should not go infero-medial to the Rubius sulcus. The umbilical sulcus and Rubius sulcus, that we can draw that the presentation, there was a very nice diagram. Don't go infero-medial to the Rubius sulcus. If Rubius sulcus is not present, then what to do? If the Hartmann pouch is lying medial to the CVD, always consider the option of laparoscopic subtotal cholecystomy. If you cannot dissect the Kellogg's triangle, if you cannot identify the cystic duct or cystic artery pedicle, always consider the option for laparoscopic partial cholecystectomy in that case.
So you have to take care of this Rubius circle.
It's always better to be superior to the Rubius sulcus if that is present. Almost 80% cases we are going to have it. In 20% cases, these Rubius sulcus are not there, that is fused.
Dr. Nimesh, would you like to tell something about the dissection of gallbladder from the liver bed? Because there the problem of accessory duct, which Dr. Sanjay has raised, will also come in view. And you may go too deep, you are taking the biopsy from the liver. So what is the ideal way? In what way we should proceed the dissection of gallbladder from the liver?
In normal conditions, it has been seen that in the gallbladder and the gallbladder bed there is a fibrous tissue, avascular areas which can be completely dissected, and gallbladder can be dissected from the liver bed. As mostly hooks are used in this condition, but my preference choice is using the spatula. Spatula has two advantages. By tip, we can use it as a hook, giving the sharp dissection, and with the back of the spatula, we can give the current, so having the coagulation, because that covers the larger area. So it is important when we dissect the gallbladder from the liver bed, we have to make sure that hemostasis should be achieved same by same. We can't wait कि suppose we have removed the gallbladder and after that we will have to achieve the hemostasis in the liver bed, because once gallbladder has been removed from the liver bed, then the advantage of retraction, having the exposure of the gallbladder bed, will not be available to you. So important is you have to dissect it and you have to achieve the hemostasis. Then lastly, before removing the gallbladder from the gallbladder bed, we have to properly irrigate with the water and suck, so that all the fluid, all the blood, all the clots should be removed. Then we have to see that if there is any leakage from the gallbladder bed, because sometimes what happens due to the blood, there is no we can't assess that there is leakage from the gallbladder bed. So we have to see that any bile leakage from the gallbladder bed is there. If it is seen that it is leakage from gallbladder bed, then we have to wait. We have to go take our laparoscope there and see the size of the lumen from where it is leakage. If it is leakage from the gallbladder bed, then it can be small, less than 3 mm. It can be coagulated. It can be sutured. If you see for the sectoral duct less than 3 meter, you can ligate it. If it is more than 3 meter, then you have to do the Roux-en-Y anastomosis. So at least if your expertise is not there, you can't do the Roux-en-Y anastomosis. At least cannulate it and put the inflammatory tube outside, so that later on it can be repaired. So it is very important while you dissecting that till you are not being sure for the achieving of the hemostasis from the gallbladder bed, you are sure that there is no bile leakage from the gallbladder bed, till then you should not remove the last part of the gallbladder from the liver.
So he is very well said that spatula can be used for the purpose of dissecting as well as coagulating the bed area. And if you are able to see, the wise thing is you put a gauze piece there after removing the gallbladder, and if there is any bile stain on that gauze, you should suspect that something is wrong. You should be cautious. that why the bite is, ideally the bite should not be there in the gauge piece. So already this part has been covered, that the lower 1/3 of the gallbladder is separated from the liver, and only two structures should be seen entering the gallbladder. It is the wisest way of avoiding the injury to other important structures. Or consider an intra-operative timeout. This is important. Sometimes whenever you are stuck up or you feel that you are not able to proceed further, it is better to wait and take 2 deep breaths, and later you can continue the dissection. It is better not to cut out the important structure rather than waiting. Waiting is timeout should be there in the operative procedure, and you should be sure the critical view has been achieved. This is the diagrammatic representation. Difficult gallbladder, already these aspects we have covered. Now, recognize when the dissection is approaching a zone of significant risk and halt the dissection before entering the zone. Failure to obtain adequate exposure of the anatomy of the hepatocystic triangle, or when the dissection is not progressing due to the bleeding, inflammation or fibrosis. You should be able not to clip. Sometimes it is difficult to blindly putting a clip. It is better you should be well versed with the endosuturing and endoknotting, which Dr. Shashank is all the time emphasizing. Every surgeon should know how to do endoknotting and endosuturing. Now, regarding this, I will like to ask Professor Jain sir, B.K. Jain sir, that when we should decide that we should open the case rather than proceeding with laparoscopic cholecystectomy, because we should have the safety in mind. When we should, in what situation we should decide that now we should abandon the procedure and now we will like to open the case, conversion to laparotomy.
I think when with the time we are not making progress in the operation due to difficult anatomy, I think, and you don't have any more help available in the theatre, then probably it is right time before you do mishaps, you should decide for conversion to open.
Message is never hesitate to call your colleague. Don't feel shy. Your colleague will come with a fresh mind and he is joining you as a fresh person. He will be assisting and he will be giving proper guidance, and you will feel more confident when some other colleague is also there with you. So never hesitate. कोई ईगो प्रॉब्लम नहीं होनी चाहिए अपने colleague को बुलाने के लिए.
Sir, when callous triangle is frozen up and this dissection is too difficult to do, would we abandon the procedure right away, just put a drain and come out?
When no help is there, nothing you can do much, should we abandon the cholecystectomy and put the procedure later on?
This can be done if you are outside, not in the tertiary centers.
Sir, because we are not in the institutional setup, we are just in the private setup, and there is no help from
this is again the bailout technique. You do not have any working hand on the second opinion to help you out. It is better to abandon, put the drain, abandon the procedure and send the patient to the higher centers. You can talk to the
patients
concerned. The documentation is also important one. Second, if you are sending to the higher centers, if you know some surgeon there, so talk to them and tell them these were the intra-op findings. I was unable to proceed further. There were frozen callots or whatever the thing, because so that the next time if they are receiving the patient, they have something in their mind. Okay, yes, this was the finding that time. So this is the again one of the bailout procedure. You can approach it. I mean, easily. One more thing is that sir already mentioned is the tube cholecystoscopy. Even if that cannot be done, putting the brain perfectly fine and refer the patient to the higher center with proper documentation and the conversation. So,
Thank you.
For better patient management.
Now, after discussing so much on theoretical aspect, I have got some intraoperative scenario in which we will like to have the opinion of the panel, what they are supposed to do. Suppose there is a bleeding from the port side. You are putting a drain or port and the bleeding occurs. What we should do, sir? Dr. Nilesh, please.
When we have put the port and then we see that there is bleeding from that port side. First of all, when we put the telescope, then it is not possible कि हाँ कि आपको दिखेगा नहीं तब. उसके बाद later on जब आप when you put the second port, तब mostly आपको दिखता है. But sometimes what happens जो आपका telescopic port है, later on वहाँ पे blood जब बार-बार आपको वो कर रहा है आ रहा है, तो you can suspect कि there may be bleeding. So first of all, when you have seen that after inserting the port there is bleeding, you can just put the port, move the port downside so that touches outside touches the skin and inside touches the inside of the abdomen. It gives the pressure over the bleeding from see where from which part medial, lateral, upper, lower, from which part bleeding is there, and you can give the pressure on that. नीचे से आपने पोर्ट्स को स्किन की ओर मूव किया तो नीचे से प्रेशर पड़ेगा, ऊपर से आप हैंड से प्रेशर दीजिए और किसी से प्रेशर देना है. For how much time? We have to give at least 5 to 10 minutes, which is equal to the clotting and the bleeding time. So you have to give at least 10 minute pressure, fully 10-minute pressure, so that the bleeding can be stopped. After 10 minutes, when you remove the pressure, you see that bleeding will stop. If it is not stopping, still it is continuing, then you have the option that you can explore that port and you can put the sutures under vision from the bleeding itself.
Just want to add one more thing. The bleeding will start from the skin incision. You are giving like a 10 mm trocar after injecting the local, and you are giving the incision. Okay, so bleeding can be from the skin. So if this is like you can see the sputter, you can take at that time nicely. You can use the hook. You can just coagulate them properly. And with this supraumbilical trocar, this is not a problem. The main problem is with the epigastric trocar. While removing the specimen, you are dilating the trocar, the tract. So that time the superior epigastric vessel can avulse, and you have the bleeding that time. So that can be seen while you are removing the trocar. So see from the supraumbilical whether some blood is trickling or not. So that time you can, as sir already mentioned, you can take the suture, figure of it nicely and see whether the bleeding has been stopped or not. Don't be in a hurry to close it, ki, okay, bhai, next time band ho jayega. So take all these things nicely under vision, there's no bleeding, there's no blood is coming out. So only then you can close it.
Suppose in putting a first trocar, Dr. Shashank, this is a question from you. Suppose putting a first trocar in umbilical region, you have injured a major vessel. What to do now?
Putting a first trocar means the first port is usually blind insertion is there. Usually what we do, we take a Venous needle first. So it is whether we are injuring that through Venous needle, the first scenario, the blood will come out. In that scenario, don't remove the Venous needle from that side. And your intra-abdominal pressure being maintained by the flow rate of CO2. Flow rate of CO2 should not be more than 3 liters per minute. Usually क्या होता है कि जो भी इंसफलेटर में सेटिंग हो रखी है उसी पे हम जाते हैं और शुरू कर देते हैं. तो in that scenario, always check whether the flow rate should be 1 liter per minute for total volume of CO2 used 1 liter initially. 1 liter CO2 used, increase it up to 3 liter per minute. उससे क्या होगा? Even if we are inside some vascular structure, that is not going to harm the patient. You have some time. Don't remove that Venous needle and just convert it. If that is, if the flow is, if you are suspecting that we are in iliac vessels or some major vessel, convert it. But don't remove that Venous needle from that side. And take the help of other colleagues.
That will be telling the site of bleeding.
The site also, sir, and that is again
Empanada techniques.
How will you create a pneumoperitoneum when your body is in some vessel and running coming out and you are leaving the veins there?
Creating pneumoperitoneum is not important at this point. The venous needle you have inserted and you are just opening the tap and the blood is coming out. If you are inside some artery.
Yes.
So pneumoperitoneum is the secondary thing. Now the thing is you are going to
Create a pneumoperitoneum that will create a pressure.
No. We are not creating pneumoperitoneum. Don't remove that venous from that cell and just convert it.
Initial days when this laparoscopic surgery was just started, I am talking of 94, 93. One of the surgeons was putting a trocar and he has injured the major vessel.
So that's why direct trocar entry is not recommended. Usually with varices, there is roughly 20% chance of injuring some structure. But if we are going with direct trocar entry without using various needle or pneumoperitoneum, there is only 3 to 4% chance. But those 4% cases, they are difficult to
Because when you are putting the pressure, the trocar is very close to the aorta. When you are putting, so all the time you are asking the assistant to pull the abdominal wall upward.
So trocar entry should not, direct trocar entry is not recommended. Take home message for all the PGs.
Now in second situation, suppose the gallbladder is adherent or there may be a fistula formation between the gallbladder or colon. What should be done? While dissecting, you have made a small hole in the colon.
If you have diagnosed it intraoperatively and there is no peritonitis, nothing else, and you see a clean defect, you can easily repair it endoscopically. There is no issue about it. But if a perforation is big, you have a lot of spillage, then it is better to do a open laparotomy and thorough cleaning, peritoneal lavage, maybe endoscopy, whatever is needed should be done.
Same is for the duodenum because most of the time duodenum is also injured.
Just want to add one more thing. While if you are suspecting the colocystofistula and there is some tract, you can delineate it with the blunt dissection as sir initially told the blunt dissection. So either you can clip the tract with the two on the colon side, one on the end, you can divide it and see whether some pigment matter is coming or some staining in there. One. Second, I agree if there is a clean cut, you can close it.
Similar thing for the duodenum as well because
Yes,
most of the time Hartmann pouch is adhered to the duodenum and during dissection the duodenum gives way.
Since there are these staplers are available, so you can use the judicial use of the staplers, like the blue staplers, we can divide the tract without much injuring the duodenum and the colon.
Anyone else want to add it? Accidental injury to liver parenchyma with the Maryland or when you are putting a trocar. Shashank?
When you are putting first trocar after putting a venous needle, we can increase this first incision supraumbilical incision, we can increase nick so that we are using lesser pressure when putting first trocar. After insublating with venous needle, go again with the blade and increase this venous needle side so that when you are putting trocar, you will be using lesser force. When you are using lesser force, there will be lesser chances of injury. So these are some modifications people have to know.
Suppose liver parenchyma, there is a starting of bleeding from the liver surface.
If there is accidental injury to liver parenchyma with the Maryland dissector, what we can do is what I usually do, I put a gauze piece inside before operating before going for any laparoscopic procedure. Beforehand, there is a gauze piece and there is a artery forceps hanging on the gown of the assistant. And instruction is that whenever I am going to remove this gauze piece outside the patient, just remove this artery forceps.
For remembrance.
Yes. And with the help of that gauze piece, you can directly apply the pressure over that area, wait for a few minutes, and most probably the bleeding will stop. Don't try to just coagulate it or just hold it and just don't try to burn it. Just wait for few minutes, apply pressure. This is the first thing you should do. It's still not going to handle it, still bleeding is there. At PG level, ask for help. Ask for any senior's help.
So also nowadays, Flucil is available, which can be applied both open as well as the laparoscopic surgery. It is very convenient to apply, and now mostly in all the tertiary care centers these are available because they are going for the major surgery. Bleeding are previously we are using sponges and surgical vera. Now these are Flucil, they are very efficient by just spraying over the bleeding areas of the liver and other bleeding areas. They can stop the bleeding. So I suggest that it should 1 or 2 pieces should be available in each and every OT. It is not very costly and it will help in
It
this
is
situation.
in liquid form.
It is in the liquid form. Pre-formed, it has to mix and it has to be applied over the bleeding area. It is available.
Another important thing, and this is very at times very alarming, that while doing the carotid triangle dissection, cystic artery starts bleeding.
So we are having a video call.
Yes, we can start it. That's all. Now you can see the artery is being cut.
This is another complication. So with your permission, can I ask?
Yes, one more.
In the first video for PGs, what was the finding, why there was bleeding, and the surgeon applied what, whether that was applied correctly, what was the mistake? Anybody in the PG? So basically, one branch from the cystic artery that was cut and that was dealt with applying a liga clip. But the liga clip, the distal part was applied over the liver parenchyma also, along with that cystic duct. So we should take care of that. We should not take the liver parenchyma along with that. Suppose, are there any other method for managing these type of cases? If Dr. Dheeraj asked sir in the previous presentation, we must have a bipolar cautery. Bipolar cautery, one of the option, liga clips, yes. Second option, in that case, but the take home message is, घबराना नहीं है, bleeding हो रही है. Another thing we can do is, we can use our left hand and just press over that bleeding point. with the help of gallbladder body, apply pressure, and you will have some time for managing this case. In second video, the problem was with the use of semi-traumatic forceps, gallbladder fundus holding. So gallbladder fundus should always be held with atraumatic forceps, as suggested by Dheeraj. Always use atraumatic forceps for holding the fundus of gallbladder, not the semi-traumatic and traumatic forceps. Thank you.
Now, there is a situation where after clipping the cystic duct, two openings are seen on the medial side towards the CBD. What is the possibility? Dr. Nivesh, yeah, Dr. Rathore, whosoever wants.
You have cut the CBD. This is the likely event. So this is very alarming. You have to think you have done the major mistake, and you have to rectify. If you can do that time on table, best way. Otherwise, you can put the drain and refer the patient to the heart center for further management.
So remember, there should not be two openings after cutting the cystic duct. This we have already done. Again, not much to be added about the spillage of bile and stone. You can remove the stone and the collected bile there. What do you suggest regarding the use of endobag? Because I remember one of my teachers, he was operated for left cholecystectomy. Gallbladder was taken without the bag, and 3 months later, there was a secondary in the port. So, what do you suggest to your PGs? Routinely we should use the endobag?
I think the routine use of endobag is not needed. One, since the chances of malignancy is not much, maybe less than 1 or 2%. Depending upon the patient profile, if you are suspecting any malignancy on the basis of imaging, like on the basis of ultrasound, there is some problem in the gallbladder, some gallbladder thickening on the CT scan, still there is some doubt. So in the doubtful condition, yes, you can use the endobag to avoid the spillage. One. Second, in the benign condition, like the multiple stones, the gallbladder is ruptured, so that you can use the endobag to avoid the tract seeding of the stone, later on making the fistula. So routine use is not needed. Careful use, especially where you have a doubt about the malignancy that is not confirmed. And one is the full of stones, the gallbladder is ruptured multiple sides, so that is the condition.
So judicious use of the bag should be there. Sir, I will like to ask whether we should put a drain or not, because young generation now, they are saying, when we have done such a neat and clean dissection, what is the use of drain? But what Dr. Bhatia was saying in the morning, that you must put a drain. मैं तो आज तक का drain डालता हूँ, gallbladder करूँगा तो drain जरूर डालूँ. What is your opinion?
I will like to say that a surgeon must be able to assess the quality or the standard of the cholecystectomy done by him, whether it is satisfactory or not, whether it is unremarkable or not. If there is something which is out of the place, then he should do put drain. If he thinks everything is satisfactory, he takes his time out, inspect everything, no bleeding, no bile leak, there is no need of putting a drainage tube. It has a lot of morbidity for the patient.
In my opinion, putting the drain is not a much problem. Like if you are putting the drain and removing early in the morning, so it will not add much morbidity. Okay, because see, the opening is there and the pain remains the same. So, and one more thing, during the time of dissection, the drain will remove the toxic fluid in that environment. So yes, the routine use is not needed depending upon the surgeon's preference, but yes, you want to sleep nicely in the night without any problem, and you know that you are are going to remove the drain in the early in the morning, maybe after round, and the cost is not much. So
But there are lots of Western studies on this, lots, and everyone is saying drain. They used to say, when in doubt, put the drain. That is true still, but they are saying now, when in doubt, do not put the drain. Put the drain when only if it is indicated. You have done a spillage, you have seen the infection, you are not happy with the dissection, whatever. They say don't put the drain. And they have studied on 10,000 plus cases. There are many studies, sir. अगर आप पढ़ेंगे इसको, so there are many studies on this. So
You want to add?
it's a personal view, but I put a drain only when I am suspecting something.
See, if you don't put a drain and something goes wrong, what will be the situation in the court of law?
Patient will tell you. Patient teachers will tell you if something is.
Sir, in my opinion, what happens? What I want to continue a question that if you don't put the drain, what will happen? It will happen that there will be next day patient will be toxic, having some symptoms of the jaundice, having the some on you see that there is some correction in the right hypochondrium, all will be there. So how will you proceed? You will proceed. You have to do the ultrasound. First thing you comes in your mind that there may be CBD injury or some biliary injury. What you do? You do the ultrasound, you do the MRI, and if collection is there, first thing what has to done, you have to do the any pigtail insertion or insertion so that it can be trained. So if these facilities are available with you and you can do it in-house, then it is well and fine. You can go without the train. If it your uncomplicated case is there, no issues, then you can go for it. If you see there's your plus minus and you have all these facilities in your house, then you can go with the without the train. But if these facilities are not there, suppose for the ultrasound you have to send to other place. For the MRCP, it has to send other place, cost has to be beared. If for the insertion of the pigtail, you have to send for the ultrasound center. If these are there, then you should put the drain, because once these are there, patient have to patient go other facilities. Patient have some issues. Finance may be involved. So in all these cases, simple by putting one drain will remove all this your anxiety and the patient's problem. So in my opinion, then we have to put the drain. If facilities are available, then there.
one point I would like to.
As far as the drain is concerned, whenever we are performing laparoscopic cholecystectomy, we are using carbon dioxide. And it has been seen scientifically that the water content that is present inside peritoneal cavity when it reacts or meets CO2, it forms a weak carbonic acid. It acts like some sort of antibacterial. And let's say a procedure is going on half an hour, 1 hour, 1.5 hours. It's always better to drain this. Put a drain, remove it next morning. Weak carbonic acid or any extra fluid or surgical stress, whatever you are giving to the patient, reactionary body fluid will be there, and that if you are taking it out just by putting a drain and just remove it next day, there is no harm.
I hear it with a little difference with Dr. Rathore. If we have put the drain, then at least it should be removed after 24 hours, not the next morning. Patient should mobilize. If you are doubt and put, then the next morning, not next morning ki kuch nahi aa raha hai, nikal do.
Talking about the like you have done the case early in the morning, at night.
Either not to put or put, then give it at least 24 hours for removal.
Looking the patient
Sir, I have got a very specific question about it. What Dr. Jain said, if in doubt, put in a drain, yes. But that other dictum is also true. Drains does not drain.
No.
Yes.
I don't believe it.
But what you have said correctly, sir, whenever in doubt, go for a mom's test. I have to operate upon my mom or brother.
I would like to put.
What is my choice? I'll put in a drain. That is the correct answer. And drain will not drain. Mind it, it will not drain if it is not placed correctly.
Equally important.
The problem is we are putting a drain which is not placed correctly. That is why it is not draining.
This is very important. Sometimes when you want to put a drain, instead of putting in subhepatic space, you are just putting just below the liver, and it will not raise because by gravity it will be in the hepatorenal pouch collection. Now, lastly, I want to sum up because time is running short and we have another session also. So, Anuj, you please tell how to suspect post-operative complication has occurred.
Most of the point we have discussed in drain point only. So yes, obviously if you have a drain and you see a good quantity of blood or bile in it, then you have to be cautious about it. And if you haven't put a drain, or even you put a drain and patient is having toxic feature in the next morning, patient is having tachycardia, fever, hypotension, toxic look, yellowish coloring of eye, then you should investigate the patient. It should ring the bell in your mind if something has gone wrong. And that's why comes the importance of recording of the surgery. You should review your surgery, where it went wrong, and it really helps you diagnose the problem when you go retrospectively after seeing the patient. So vigilance is very important, but most of the time we are doing as a daycare surgery. We call patient in the morning, early morning, NPO, and then operate and discharge in the evening. So in such conditions you might miss it. So sir is also right, you should observe patient at least for 24 hours minimum.
To add one thing, even in the next day, patient may not have any toxic symptoms, but if you have put it in, the brain may have some bile in the tube, or maybe that it may be less than 10 ml or 20 ml. Patient is clinically fine. So that thing also keep in mind, this can happen. So just observe the patient carefully over a period of 1 day or 2 days, and do the needful, do all the investigation if needed, if the symptoms persist.
Sometimes small bile canaliculi can be cut during dissection of the gallbladder from the liver. So that will give some amount of bile, 10 ml, 20 ml. So not to be in a hurry to take out the drain. That's right. I think we have tried to cover almost every aspect, and thank you my panelists. Everybody has participated nicely and given information which is needed for the whole.
Thank you so much, sir. That was an excellent discussion on safe cholecystectomy practices. Before concluding this panel discussion, I would like to felicitate our guests from the dais, requesting Dr. Y.P. Monga, sir, to please felicitate Dr. D.K. Jain, sir. Requesting Dr. Dhiraj Valyan, sir, to felicitate Dr. Nivesh Atwal, sir. Requesting Dr. Madhubala Gaur, ma'am, to kindly felicitate Dr. Anuj Sharma, sir. Requesting Dr. Sanjay Pandey, sir, to kindly felicitate Dr. Yashwant Rathore, sir.
Yes, sir. इसका point देखो किधर मैंने तो मुझे दो मैं तो
Requesting Dr. Sudhir Rathi, sir, to kindly felicitate Dr. Shashank Mishra, sir. Finally, requesting Dr. Rishi Bhatia, sir, to please felicitate our well-regarded monitor, Dr. Maheshwari, sir.
Gallbladder disease is common all over the world and are very common in northern India. Bile duct injury being the commonest complication are a cause of numerous litigations. There has been a constant endeavor to identify the factors that favor the safer outcome during a laparoscopic cholecystectomy. Traditionally, various attempts have been made, but there is no clear set of parameters which can determine the outcome of the surgery. To standardize the level of difficulty, a new objective scoring system has been devised to create the various parameters and apply it for a safer outcome. The Icf scoring system, that is the Intraoperative Clinical Hepatobiliary Score. It is entirely a new scoring system concept in surgery literature till date, based on objective scores to find out operative difficulty levels and its recommendation in laparoscopic cholecystectomy for a safer outcome. Let's put our hands together for Dr. Shashank Mishra, Professor, Department of Surgery, Subharti Medical College. Sir has always been inclined towards various research work, devising new standards for surgical practice in the field of surgery. He has been a member of various national and international societies.
Sorry to interrupt you, but Dr. Madhu, she asked me कि she wants to say few words regarding the just finished panel.
I want to give two comments on the first session. The first point is regarding the subtotal cholecystectomy, whether one should do subtotal cholecystectomy laparoscopically or preference should be complete cholecystectomy by open method. Nivesh sir said that we should go for complete cholecystectomy by open method, and Pandey sir was his comment was, what about the new surgeons who are unable to perform the open cholecystectomy? I think while operating surgeon should give minimum 100% to patient and more than that. Like if surgeon is not confident that he cannot complete the procedure by open, he should be aware of all complications, all consequences of his procedure. And if he or she is not confident that they are unable to perform the open procedure, there should be always second standby surgeon who know the convert the procedure to open method. In institutional practice, it is okay. But in private practice also, one should have standby surgeon who will complete the procedure by open method. Because in court, you cannot say that I don't know how to operate, how to do open cholecystectomy. So one should conversion is wisdom and not failure. Second comment is regarding the injury to large vessels. All large vessels, by God's grace, all vessels are retroperitoneal. They are covered anteriorly by viscera and posteriorly by vertebral column. I don't know why in all conferences or workshops this complication is discussed. Injury to large vessels. How with the entry of first trocar, means when we put Willis needle, abdominal wall is already elevated. There is pneumoperitoneum, then there is viscera, and the vessels, large vessels are retroperitoneal. So my question is, how can surgeon injure large vessel? It is not possible if he or she is putting trocar in control manner. And if he is injuring, then I think he is almost equal to criminal. His surgical skills are not perfect. So said technique should be like sir said that we should widen the incision and put the trocar in control manner without any undue force. Last thing is, surgery is not a glamorous field, and doing surgery is not doing stunt. For doing safe surgery, we should have knowledge, skill and patience. And last is respect and love for tissue, so that you will not injure the tissue, you will be safe and patient will be also safe. Thank you.
Thank you, ma'am. Having said that, I request you to please come on stage and chair the session. Please welcome on stage Dr. Madhuvala Gaur, ma'am. Please. Thank you.
Thank you, Dr. Madhu, for your feedback. Whenever we are not following basic principles of anyone can injure the islet vessels. whenever we are using a long length of various needles. So, just in continuation of safe cholecystectomy, I am directly coming to an objective scoring system. We have already attended 2 interactions, 1 panel discussion and 1 lecture. And in both the interactions, many things we have covered. But the only thing remaining is there any objective conglomeration of all the factors, pre-operative as well as intra-operative assessment? Jain sir has very widely covered, very nicely covered the pre-operative preparation. Can anything exist? Can we combine all the factors and can we have some objective scoring system that anybody can calculate it and we can communicate with each other, just a matter of a score? Just like in severe head injury, we are using GC scoring, E4, V5, M6, normal, E1, V1, M1, the minimum one. Similarly, this is an atom. Let's go back to very quickly, 2015. I was a unit in charge of that unit and my AP was there. I asked him to go for a laparoscopic cholecystectomy in the OT. उससे पूछा हाँ भी कैसा था? सर ठीक था. 2-4 दिन बाद किसी और उसमें सिनेरियो में दिया, क्या हुआ सर, ठीक हो गया? हाँ सर, कॉलवर्ड कैसा था, कैसा कैलॉट्स था? सर ठीक था सर, हो गया सर. हर केस में यही समझ में नहीं आता था कि वो ठीक होता क्या है, जब भी कॉम्प्लिकेशंस हो की जाती. धीरे धीरे करके at that time in 2015 we started with a sense of these factors what the learned faculties already discussed, and we just started collecting data. In 2019 we devised this scoring system in this our institute and registered it, and finally we are using it, and with the use of this ICH score at present we have already done around 1200 cholecystectomies using this ICH score. So quickly we are going to see what is this. Basically this intraoperative clinical hepatobiliary score has 2 components: pre-operative assessment and post-operative assessment or intraoperative assessment. So pre-operative assessment constitutes part A and intraoperative assessment is part B. The minimum scoring for part A is 0, maximum scoring is 20. Similarly, intraoperative minimum scoring is 0 and maximum scoring is 20. What they have taken? The routine thing. For long, any postgraduate student or undergraduate students, what we are going to teach? Okay, now you have come, just go to the ward and take the case, and what is to be taken? First, history. Obviously a case of gallbladder stone disease we are talking about. First, go with the history, then clinical examination, then biochemical parameters and sonographic findings of hepatobiliary. So we have taken these 4 factors in part A assessments. Part B, 2 organs are very important. One is gallbladder and related hepatobiliary anatomy related with the gallbladder, and second one is liver, hepatic. So in intraoperative there are 2 broad factors: gallbladder factors and hepatic factors. So quickly we are just going with the part A assessment. In history component there are 4 important factors: the age of the patient, less than or equal to 40 years and more than 40 years. The maximum score for this scoring is 1. Gender, female versus male, 1. If patient is having history of hospitalization for acute cholecystitis or GB stone or gallstone pancreatitis or alcoholic pancreatitis along with gallstones within last 3 months, if that is positive, the maximum score for this factor is 4. If patient is having post-ERCP status, if yes, with CBD stent or without CBD stent. So we have included even the patients who are having polydopolithiasis and managed somewhere else with the help of ERCP. If without CVD stent, the maximum score is 2. If with CVD stent and sphincterotomy, 1. So maximum, we are going to add up all these, maximum is 4 and it is coming up, maximum is 8. This is a part of part A assessment, pre-operative assessment. The second one is clinical examination. We are taking two important things, whether patient is having previous abdominal scar, no scar 0, infraumbilical scar is 1, supraumbilical scar is 2. Maximum score is 2. If the patient is having palpable gallbladder or there is tenderness in right hypochondrium, yes, 1. Adding up, maximum is 3. So clinical examination, maximum score is 3. Part A, very easily you can remember it. 8, 3, 4, 5. Maximum score 8 in history component. Maximum score is 3 in clinical examination component. Maximum score is 4 in biochemical parameters. Maximum score is 5 in sonographic findings. This biochemical components, whether patient is having elevated serum lipase, amylase or both within last 15 days or 2 weeks. Yes, 1. Any sort of deranged liver function test. The patient having gallstone disease with deranged liver function test. 1. If patient is having simultaneously more than 11,000 raised TLC. 2. The maximum score is 4. And the last one in part A is sonography. They have taken 4 important parameters in sonographic findings. The gallbladder wall thickness, whether it is more than 3 mm or less than or equal to 3 mm. The second is pericholecystic fluid collection, then impacted stone, and whether patient is having sonographic findings suggestive of portal hypertension, splenomegaly, some sort of venous channels, abnormal venous channels over that area, and large liver, and all other features of portal hypertension or sonography. If that is there, the maximum score is 2. Adding up, maximum is 5. So, part A, 8 plus 3, 11, plus 4, 15, plus 5, 20. Maximum is 20, part A. Pre-operative assessment. At this stage, we can always tell any patient beforehand, okay, how the surgery is going to be expected. What would be the possible complications? If suppose any patient is coming in the pre-operative assessment, the score is, let's say, around 18. It means in intraoperative assessment, it is very likely, even if you are going to add 5 or 6 or let's say 6, 18 plus 6, 24. This is going to be more than 20. Means out of 40, patient is having ICF score 24. And that is correlating with difficulty level 2B. So we'll discuss very quickly what is difficulty level 2B and what are the recommendations we can have. This is an attempt to objectify the things, to set some. First component is whether gallbladder is visualized out of liver margin more than 3 cm. Yes or no. If not, the score is 1. Additions with gallbladder, whether the only greater omentum is attached, colon plus minus greater omentum, duodenum plus minus colon plus greater omentum, stomach, duodenum, colon, greater omentum plus minus other surrounding structures are adhered to the gallbladder. Accordingly, the score can be given. In continuation of this gallbladder factors, the third important thing is whether there is excessive fat and fibrous tissue over Calot's triangle, one of the important component of critical view of safety. Yes, 1. Whether posterior fold visualization of Calot's triangle is there or not. And all these factors, we have not done any intervention. This is the first laparoscopic port view. Thus we have retracted the liver, trying to retract it, we have not done any intervention. What is the inspection finding? And the last one is whether the gallbladder is devascularized, gangrenous, empyema, features are there, mucocele or contracted fibrous gallbladder. The maximum score is 2. So adding up all these 5 points, these two and these three, the maximum score is 10 in gallbladder. Part B, intraoperative assessment. And the last one is hepatic factors. We have taken 4 important factors in hepatic one, whether the Rouvier sulcus is present or not. If present, yes, obviously that is going to guide us during intraoperative procedure. Don't go inferior to this. If it is not present, means no, Rouvier sulcus is not present, means some difficulty is going to be there. So one. Second is features of perihepatitis and perihepatic fibrous bands. Again one. And last 2 factors are very important. If there is pathogenic presentation of neck of gallbladder inferior to Rouvier sulcus, if Rouvier sulcus is visualized. If Rouvier sulcus is not visualized, the next line. Or if the neck of GB is presenting inferior or medial to common bile duct, if Rouvier sulcus is absent. So both the things are here. Whether Rouvier sulcus is present in 80% of the patient, inferior. If Rouvier sulcus is absent, look for inferior presentation of heartlands medial to CVD. If that is lying there, the maximum score is 4. And finally, if there is some anomalous congenital presentation of hepatobiliary, all the anomalies fall under this point. Hepatobiliary, maximum score is 4. Adding up all these hepatic factors, total is 10. So finally, this is the summary of what we have discussed till now. The upper line, that is part A, pre-operative assessment, 8 maximum score for history components, 3 maximum score for clinical components, 4 for biochemical components, and 5 for sonography, ultrasound findings. Maximum 20, and 10 for gallbladder factors and 10 for hepatic factors. Collectively taken, the maximum score for ICF score is 40 and minimum score is 0. As the score increases, the difficulty levels in cholecystectomy increases. So why this is important? How to calculate it? We can, if we know all these factors, we can manually calculate it. Otherwise, there is an app, Gallbladder Walk, with the name of Gallbladder Walk. That is available in Play Store. Will be activated within the next 24 to 48 hours. Annual renewal is required. For the last 3 years, we are using it. It will be active. And there is an URL in the last line. Presently, we can use this URL for our laptop calculation. It hardly takes 30 seconds to 1 minute. Important point, how to document it. ICH score. This is a screenshot of laptop, if that is visible. Here we can see the figure that is inside the circle. If it is visible here, yes. This is correlating with level 2A difficulty. What is level 2A difficulty? Shortly we'll just discuss. Here we can see the normal version of documentation of ICH scoring is H7C2B3S2 space G5H1. Here H, the first part, denotes part A assessment, pre-operative, and the second part denotes intraoperative assessment. First part H stands for history. The score is 7 for this particular patient. Then clinical components, examination 2, then biochemical 3, and sonography 2. The GA, gallbladder factors 5 and hepatic 1. All these, if you are going to add these figures, 7 plus 2, 9, plus 3, 12, plus 2, 14, plus 5, 19, and plus 1, 20. So ICH score is 20. 20 belongs to level 2A. What is this level 2A? This is the last slide of my presentation here, and this is very important. Here the first column, level 1A, we can write either in Roman or in numeral. 1A, there are 5 difficulty levels in this ICH, based on this ICH score, and namely level 1A, level 1B, 2A, 2B, and the level 3. 1A, the ICF score range is 0 to 5. 1B, 6 to 10. 2A, 11 to 20. 2B, 21 to 30. And finally, level 3, 31 to 40. Okay, we have calculated ICF score. What is the use? अभी हमारे सामने प्रॉब्लम ये आती है कि ओके पीजी रेजिडेंट्स there are juniors are there, which type of case we can allow them to perform under guidance. So in this recommendation, any case of gallstone disease belonging to level 1A or level 1B, we can safely allow under guidance. And in both the levels, laparoscopic cholecystectomy is feasible. Any technique can be adopted, whether cells or 2-port or 3-port or standard 4-port. Any technique can be adopted for level 1A. Difficulty. Resident under guidance can perform. Level 1B, sometimes it may require. अगर आप 2 port से करते हैं and the score is level 1B, consider for some extra port. 2 वाले 3 पे आ जाएं, 3 वाले 4 पे if needed. And following this, the level 2A. This level 2 and 2A, 2B and level 3. Most common type of patients falling under these difficulty levels are gallstone, post-gallstone pancreatitis. After 6 weeks, we are planning for elective cholecystectomy. These type of patients, they usually fall under level 2A and 2B. Here, level 2B is a grey area. If the surgeon is experienced, even level 2B difficulty gallbladder patients can be managed with laparoscopic cholecystectomy. Otherwise, in level 2A, Calot's dissection with gauze or suction means blood dissection is preferable. Use of endoligature is recommended and drain must be placed beyond level 2A. Level 1A, 1B, it's your choice as we have discussed in panel discussion, but from level 2A onwards, it is recommended to put a drain. Then in level 2B and level 3, here's the scenario changes. In level 2B, again, already told that it's a grey area, means if you are experienced enough, you can go with the laparoscopic cholecystectomy. If you are not having so much of experience, always consider laparoscopic subtotal cholecystectomy according to the need. If the calots is not clear, LSC type 2 is the choice. If gallbladder bed is not clear, not unfriendly, if it is unfriendly, type 1 is the choice. If both are difficult to manage, type 3 can be done. Usually more than 4 ports are required, and don't hesitate to make an extra port. Don't suddenly jump, okay, I am going to convert it. Have patience, put an extra port and just do it. In my opinion, if you cannot operate any gallbladder with the laparoscope, if the calots is frozen, in my personal opinion, I may be wrong, you cannot operate that patient even after opening. If calots is so much frozen, if you cannot dissect it, you cannot operate even if you are going to open it up. Then last one, our use of energy sources are recommended in level 2B, and drain must be there. Use of endoligature or endosuturing whenever required. And finally, the level 3. Level 3 gallbladder is really difficult to manage. Dheeraj sir was saying in the morning lecture that जो newcomers हैं उनको simple gallbladder लगता है करते रहो, but difficult कब आ जाएगा पता नहीं चलेगा. Then is there any objective criteria? कैसे पता करें कि कौन सा difficult हो सकता है? Operation table पे जाने से पहले. This is one of the method we can suggest. So LSC type 1, type 2. In this level 3 difficulty, fundus first method is preferable. If you know how to go with fundus first method, always this is preferable in level 3 difficulty gallbladder stones. Usually more than 4 ports are required for managing these type of cases, and all the recommendations that is given in level 2B, it is used here. Use of level 2B dissection, hemostasis and suturing methods are recommended. Plus here, just please pay attention that in level 2B and level 3, there is plus drain, there is no plus minus drain. In level 2A, there is plus minus drain. You may or may not put according to your choice. But level 2B, level 3, you must put a drain. And the conversion to open. In level 3 gallbladder, this conversion to open is an option for you. Conversion to open doesn't mean you have committed some mistake, then only you are going to open it. This is an option. As rightly said by Jan sir, if the surgery is not progressing for next 20 minutes, you are struggling, this is one of the options. Open conversion in level 3 difficulty. That's all sir. And this one quickly we'll go through what is level 1. A small 30 seconds video, just a glimpse कि हाँ ऐसा gallbladder दिखाई देता है level 1A में क्या होता है, 1B में क्या होता है. Now this is quickly we are going 30 seconds video. This is probably level 1A. This is one of the example. ऐसा दिखाई देता है for PGs level 1A difficult and followed by इसमें बैक कैसे देंगे भाई शुभम this side then level 1B here you can see this the level 1B we are having two videos. And one is having, it's a sort of process, means ICHBS 8 we are going to see in level 1B and ICHBS 10 we are also going to see, and both fall under level 1B difficulty. ICHBS scoring 8, this is 8, level 1B. First example, I am just putting here the inspection finding. The neck of the gallbladder, the Hartmann pouch that is infero-medial to the Rubier's sulcus. This is ICHBS 8. And what about this ICHBS 10? Both are in level 1B difficulty. These are the cases we can always allow our PG to do with obviously under guidance. This is the same level 1B, the ICHBS score 10. And this is level 2A. Again we are having ICHBS 12 score, 15 score and 20 score. So ICHBS 12. Is it functional? This is ICHBS 12. Suddenly you can very well delineate that the difficulty level, the first impression, the snapshots we are getting by going through these videos, the difficulty level is increasing. This is ICHBS 12. Then ICHBS 15. This is ICHBS 15. I'm operating whatever we have done. And this is ICHBS 20. This is ICHBS 20. So up to level 1A and 1B we can go with easily. We can tell any of our junior is having, let's say, 3 or 4 years of experience. Sir, please. Sir.
How you have validated your data?
Sir, actually I have presented this in 2019.
Your presentation is almost over, but you have not told us how you validate.
Sir,
how
actually,
you come to conclusion that these findings and this recommendation match.
The first time, sir, when we devised this scoring system, we have presented this in a conference here itself with 530 patients, with all the data, with the statistical.
Have you published your paper in a format?
Sir, still we are increasing the population. We are at present we have reached 1200 patients, and this is our experience here. And yes, publication has been done, but in the form of thesis.
How you have validated your data? How you have think you have accepted? You see, you have some observation, you have some conclusions or recommendations.
With the outcome, sir. With the outcome, sir.
What is the method?
That is a very big presentation here. I was allowed at last. So I'll show it up to you. Now, in continuation with this, as far as this is ICF 24. This is ICF 24. Level 2B difficulty. This is level 2B difficulty. And from here, this is a gray zone. If you are experienced enough, we can always yes. कुछ लोग बोलेंगे नहीं इसमें तो हम लैब खोली कर लेंगे, बिल्कुल कर लेंगे. But if you are not experienced, this is the part where you must consider the role of laparoscopic subtotal cholecystectomy. Obviously the callots अगर ठीक से नहीं मिल रहा है तो type 2 go with the LSC type 2. जो लोग एक्सपीरियंस है obviously इसमें भी laparoscopic cholecystectomy करेंगे. So this is a simple suggestion of just, and this is one of the example for level 3 ICHBS 32. This is one of the example of level 3 difficulty of gallbladder. ICHBS scoring was in this patient was 32, taking consideration of all the pre-operative as well as intra-operative parameters. And still I would like to request all of us from the faculty from all other medical colleges that we can adopt, we can try this, give your suggestions, give your feedback, try at your institute. This is just an attempt to objectify the things. अभी हम हर एक कॉन्फ्रेंस में अलग अलग जाते हैं, हर पैनल डिस्कशन में देखते हैं, हर कोई अपनी अपनी चीजें बोलती है, बट फॉर द न्यू कमर्स, फॉर द बिगनर्स, उनके लिए बड़ी दिक्कत होती है. जब मैं भी था सर, मैं जाता था, मुझे भी बहुत से सीनियर्स लोगों ने बहुत कुछ बताया, लेकिन दिमाग में हर चीजें अलग पड़ी रहती थी. दिस इज जस्ट एन अटेम्प्ट टू कंबाइन ऑल दीज थिंग्स, प्री ऑपरेटिव एंड इंट्रा ऑपरेटिव असेसमेंट.
Okay, Shisham, sir, when you publish a paper, the summary of the paper is given in 500 words.
Sir.
And there you have to describe the methodology.
Sir.
So I don't think this is a good thing that there is so much of data that I cannot present in this time. So
give me some 15 minutes. I'll just record.
I don't want to continue. I want to say that your presentation
Sir.
should have mentioned the methodology, how you linked your observation with your recommendations.
Sir, what we have devised, we were just going through the various patients, and these parameters we were routinely doing since RPG, which is from 2007. All the history components, clinical, we were just taking the data, and after collecting the data, we just analyze the data with the help of our biostatistician here. Okay, these are the things, and इस तरह के patients में अगर हमने ये किया laparoscopic cholecystectomy की, ये outcome आया, तो retrospectively as well as prospectively then we designed this and we did this study. उसको correlate किया with the help of TSM department here. तो जो biostatics जो data है सर वो ज़्यादा डिटेल में वही बताएंगे, लेकिन हाँ उसको correlate किया सर, जो भी outcome आया उससे. Okay, we have done in this patient. This was difficult score. Score तो सर बाद में आया. पहले तो आउटकम्स आए, स्कोर तो जब उसको डेटा को एनालाइज किया तो ये स्कोरिंग सिस्टम अपने आप निकल के आया सर. इसको हमने एक नाम दे दिया इसमें, और इसको पब्लिकेशंस इसके हुए हैं, बट इन द फॉर्म ऑफ थीसिस. अभी स्टिल आई एम एनलार्जिंग द पॉपुलेशन. व्हेनेवर मोर देन 2000 केसेस हो जाएंगे, इसको डिटेल में पब्लिश भी करेंगे. दिस वाज अ ब्रीफ introduction of how a patient of gallstone disease, various difficulty levels can look like. Any suggestions? Welcome sir, we can always improve it out. अभी तो ये starting है, इसको बल्कि आप discuss this study with Professor MC Mishra sir, एम्स के जो डायरेक्टर थे उस समय, तो उनकी नॉलेज में भी है, उनको भी मैंने ये भेजा था स्टडी 2019 में. और अभी जो जर्नल्स में पब्लिश हुए हैं वो पार्ट में हुए हैं सर, कंप्लीट नहीं हुआ. 239 केसेस का हुआ, तो इसको स्टिल वी आर इन दैट. So that's all. Thank you. Any question?
Thank you, sir. Thank you for describing about the new, entirely new concept scoring system in for describing ICF scoring system. And we are sure we take the feedbacks and we'll try to improve it as much as possible. I'll thank sir again. And now I request Dr. Madhuwala ma'am to please felicitate Dr. Shashank sir.
I have one query. Can you show me that intraoperative scoring part? My query is what score you will give for frozen cannot stack. Means you have mentioned about adhesions with greater momentum, colon with greater momentum. We operate on chronic cholecystitis also, cholelithiasis patient, and what will you would you like to give same score in acute cholecystitis with cholelithiasis and chronic cholecystitis with cholelithiasis?
Actually, as such, we have not taken into consideration the frozen Carrot triangle. These are the factors we have taken. For example, whether these additions are retromentum, colon, duodenum, stomach, all other surrounding structures, as well as excessive fat over carrot. It's a combination of that. Frozen triangle as such we have not and in the intraoperative.
Because I have given this thesis topic to my students, and when there were 2-3 such cases, I confused that what score we should give.
It's a combination of all these factors. It's a combination, could be a combination. As such, we have not taken the frozen carrot triangle in this scoring system. Any other?
Thank you.
Thank you.
Legal and ethical issues in the field of medical practices have rapidly increased over last quarter of century due to numerous reasons, which include complicated partnership of healthcare providers, variable cultures of patients, wide scope of available alternatives, and new advancements in surgical procedures. Surgeons, due to their nature of work, are more exposed to more and more medical, legal, and ethical issues. And we know that the most common complication of cholecystectomy that results in litigations is bile duct injury.
To understand the ethical-legal aspects of bile duct injury, we'd like to call on stage the panel members. Let's welcome on stage Dr. Akhilesh Mohan sir, Chief Medical Officer, District Meerut.
Gone.
Next, we'd like to call on stage Dr. Subharti sir, Professor and HOD, LLRM College. Dr. Subharti sir, Legal Advisor, Indian Medical Association, Meerut. And Advocate Vivek Saxena sir, LLRM, LLM, Advocate on Record, Supreme Court of India. Please sir. I would also request our Honorable Moderator for the session, Dr. Y.P. Ponga sir, Principal, Subharti Medical College. He is a performance-driven personnel with nearly 47 years of experience in surgery, hospital administration, teaching and team management. He has served the armed forces for nearly 39 years, rising to the rank of Surgeon Vice Admiral. He has been an honorary surgeon to the President of India during his tenure as the Director General of Health Services to the Armed Forces. He is the definition of punctuality and discipline. Let's welcome sir on stage.
Good morning, everyone. I welcome the panelists. To begin with, I will briefly go over a few slides related to the topic, and then we'll come to questions, which I will ask on the surgical aspect, very few, and mostly on the legal aspects. So this is basically to prepare ourselves or residents when they face a situation where things have gone wrong, namely the bypass injury, not the management of the injury itself, but the up to about ethical legal aspects. As we all know that it is one of the commonest surgeries performed, that is laparoscopic cholecystectomy, and the incidence of bypass injuries still continues to be at a certain level, 0.5%. And in the best of the situations, we have failed to bring it down to zero. PDI can cause severe morbidity and even mortality. This is a common cause of medical legal suits filed by the patient against surgeon. In India, the Consumer Protection Act of 1986 lays down the rights of the consumer. And there is a constitution of the consumer forum at different levels, and their powers to award monetary compensations. The financial burden. A bypass injury does increase the financial burden on the patient. In a study conducted at SGPGI, the cost of bypass injury to the patient is a median or average cost is 93,000, which is 10 times the median cost of laparoscopic cholecystectomy. In that institution, that is, it is 9,000 approximately, and the monthly income of the patient's family was found to be 11,000, which is 8.4 times the cost of the injury to manage the cause injury. So we must reduce the risk of medical legal suit being filed. So to reduce the risk, a structured written consent form detailing all common and significant complications including BDI, lower the threshold for conversion in case of a difficult cholecystectomy, and proper documentation of operative findings, high index of suspicion and low threshold for investigation of a bypass leak after cholecystectomy. Open and honest communication with the patient and relatives, timely referral of bypass patient to a biliary center with a detailed referral note. This can prevent or reduce the risk of medical legal suit being filed. BDI may be considered by the surgeons to be a complication of cholecystectomy. Most patients may accept it as an accident, but some may allege it to be an error on the part of the surgeon. Eventually, they take the recourse to legal remedy. The court of law or the consumer forum decides negligence on the part of the surgeon and awards compensation to the patients. More so if there is a delay in diagnosis or if the management is inappropriate, including an attempt to repair by a non-specialist surgeon or even later referral to a biliary center. So Consumer Forum has awarded compensation up to 1 million in one of these cases. Injury to the bile duct is an accident. To miss the bile duct injury is a mistake. And to mismanage the injury is negligence. So what sort of negligence it is, we'll discuss, we'll take this discussion, and amongst our panelists are the legal advisor. They will educate us on this aspect. Some great surgeons once told me there are only two types of gallbladder surgeons: those who have entered the CBD and those who are about to enter the CBD. The surgeon's perspective, hospital's perspective, and the patient's perspective to be kept in mind. So we start with the question: when we are taking consent from the patient, even before patient goes for a surgery, so we are already prepared that this is going to be a difficult gallbladder, which we have discussed since morning on the different fora and even the scoring system. That forewarns us that it is going to be a difficult case. Even if it is not going to be a difficult case, it is an easy case, still we should, since we are aware of the complications which can occur, how should we prepare ourselves for a disaster that may occur? So I will ask Dr. Rajiv, please tell us, the informed consent, what all components are required before we take up a patient for cholecystectomy? Informed consent.
Informed consent, what is important, any complication related to that surgery, like in gallbladder surgery, bile duct injury is important, one of the most common. It should explain in consent ki how much chance of bile duct injury in this surgery. This should be explained to at the type of consent. Ki there is a risk of, as suppose it is 0.1%. So there is a risk of complication related to bile duct 1 in 1000. So it should be written and explained. Consent should not be very much like that ki the patient attendant become afraid of that. But all the literature support should be mentioned in that consent. Ki there are the chance of bleeding injuries are so much, the biliary tract injury, bile duct injury is that much, and what are their consequences are not need to be explained, but it should mention there is a chance of injury in this operation also.
So if the patient has come to us with a disease, we explain it to him various options. Option of not operating, option of operating. If we don't operate, what will happen? And if we operate, what benefit will it give to the patient? While it gives the benefit to cure the disease, but it is associated with some complications. Patient may say, I will not get operated. So what do we do in that situation, sir? I am scared of complications, I don't want to get operated. So what do we tell the patient in that situation?
Actually, if you are a surgeon and you decide not to operate and you are scared enough, then better to refer a center of the tertiary care center, a particular unit.
No. Surgeon is not scared. Surgeon wants to operate. The patient says, now I got scared. You have told me so many complications.
That's why previously I have mentioned to tell the complication with the literature support percentage. If you are saying there are high chance of bile duct injury, the attendant will be the scared or patient. If you told that there is a risk of 1 in 1000, and I have experience of 15 year, 20 year, and you are getting operated in tertiary care student institute where is all backup facility we are having. They should explain in this form, not like that ki there is very much risk, very low risk, in the form of percentage.
I clearly. But we also have to tell the patient if he is not getting convinced with this, we have to tell him the consequences of not getting operated. The consequences of not getting operated also should be mentioned to the patient.
Definitely the complication, it's usually the gallbladder surgery is an elective surgery. In many few situations it is the emergency services. So consequences of not to get operated should explain to the patient. Should explain to the patient that the complication you may suffer if you are not going to get operated.
So legally informed consent has got four or five important components. One is that you explain the disease process to the patient and what will happen, the progress of the disease if he is not operated. And if he is operated, what are likely complications? And what is the cost of these complications? And if he undergoes additional procedures, what are the complications that could arise from those additional procedures? Dr. Subharti.
We have to tell the alternative also. ओपन सर्जरी में क्या कॉम्प्लिकेशंस होंगे, लैब कोली में क्या कॉम्प्लिकेशंस होंगे, वी हैव टू टेल आल्सो द अल्टरनेटिव. Then only patient can decide whether I have to go for cholecystectomy or open cholecystectomy.
That's right. At the same time, we also obtain consent for additional procedures as we explained in the morning, which may arise because of intraoperative findings or because of complications. So patient has to give consent for additional procedures at the same time, which may arise because of intraoperative findings or because of complications. That's right, sir.
Earlier there was the concept of informed consent, in which we have to tell each and every minute thing to the patient. Now the new concept is real consent. Real consent जिसमें मरीज के फायदे की चीजें बताई जाएं उतनी ही, और रेयर कॉम्प्लिकेशंस और रेयर ना बताई जाए, और लिखित रूप में भी उनको ना लिया जाए जिससे मरीज डर के ना भागे. तो नया फॉर्म डेवलप हो रहा है, रियल कंसेंट इंस्टेड ऑफ इन्फॉर्म्ड कंसेंट.
Any contribution on this aspect from the audience?
तो सर इसमें एक चीज जाननी थी कि व्हाट इज द लीगल रिक्वायरमेंट कि हमें माइनर कॉम्प्लिकेशंस जो होते हैं वो मेंशन करने जरूरी है. फॉर एग्जांपल कपलिंग इंजरीज आर इवन रेयरर. So should those complications be mentioned in the consent? And अगर हमने बाइंडर इंजरी मेंशन करी भी है तो क्या हम फिर लिखेंगे कि अगर होती है तो आपका करीब 90,000 रुपए का खर्चा आ सकता है, जो सर इसमें मेंशन है?
एक्चुअली ऐसे तो कमेंट करना कि जैसे 90,000 का खर्चा आता है, व्हाट इंस्टीट्यूशन इफ सपोज ही इज गेटिंग ऑपरेटेड समवेयर हियर, दैट इज नॉट. व्हाट इज बेटर टू से कि इफ ऐसा होता है तो वी हैव ए backup proper team to handle that. Actually monetary issue is the secondary. We have backup team to handle that, and it may be further require your admission, your cost of ICU as per the hospital norm. Suppose आप 3 days में कहते हैं कि हमारा hospital admission bed charge है, it may require for admission of 8-10 days. So it explains softly, not like the very rudely that 1 लाख खर्चा हो जाएगा, 1 लाख हो जाएगा. एक्सप्लेन कि as the hospital cost will increase, then automatically the at the admission and time of admission and procedure will include OT all, so that it will increase. इसमें कोई harm नहीं है. अगर particularly if patient is repeatedly asking अगर ऐसा होता है तो क्या होगा. But first that important is that कि we have proper team to handle that complication. That is more important.
सर एक सर क्वेश्चन प्रमित सर सर आज की टाइम व्हाट इज द करंट सिनेरियो, कोर्ट किस चीज को मानता है, हैंड रिटन वर्सेस प्रिंटेड फॉर्मेट की अगर कंसेंट होती है, सो इज दैट देयर एनी टेक ऑफ कोर्ट कि इसको हम मानने रखेंगे, इसको नहीं मानने रखेंगे?
I think whether it is handwritten, whether it is a handwritten, whether the consent has been obtained on a handwritten piece of paper or on any typed format, so it makes no difference. Once the consent is there, consent is there.
And
one more thing I want to add, how much evidence, with the consent from the attendant, and the evidence 1, 2, 3, only one is required or two is required. One, the close relative of the patient, suppose wife have given for husband or husband, and the addition evidence.
No, I think that what matters is the substantial, whether the substantial consent has been obtained or not. I think it is not possible to obtain consent on each and every minor aspect. But if the consent has been obtained on the substantial part, then it will be valid. It will be good enough.
सर मतलब उसमें जैसे एक तो फैमिली मेंबर हो गए, कुछ गवाह टाइप उसका साथ में कि भाई एक ने, जैसे हम लोग यूजुअली उसे वेरीफाई करते थे, कंसेंट लिया तो डॉक्टर ने अटेस्ट कर दिया कि भाई मेरी एक तो डॉक्टर ने जिसने अटेस्ट करेगी कि एंड अगर कोई डिफिकल्ट केस है तो वन वी शुड हैव एविडेंस 1 or 2, नॉट रिक्वायर्ड.
Consent is an agreement, that is a part of contract, and part of contract, one is hospital, one is doctor, one is patient. On hospital side, hospital superintendent should sign. On doctor side, doctor should sign. On patient side, patient should sign, not the attendant. If patient is well, having sound mind. As a witness, there should be two witnesses. One from the patient side and one independent. There should be independent witness that can be from attendant of the other patient or even hospital staff can be witness. So there should be two witness and signatory should be 3 persons, hospital, doctor and patient.
But what is the role of medical superintendent?
Because there is a contract between 3 parties. The operation is going on in the hospital. So there is the duty of the hospital to part in the contract. So as a representative of the hospital, there should be some official, either hospital superintendent or CMS. Doctor is operating, so doctor should sign, and patient is giving consent, so patient should sign.
So what about the smaller setups where there might not be a official or designated medical superintendent of the hospital? In a clinic setting, in an institution it is easy to have a medical superintendent. What about a private practitioner?
Hospital in charge or manager?
It means to say that we have to take consent from the patient and not from the close relative.
Absolutely.
मतलब from consent and as a witness, one close relative should or should not be there. Dr. Bhatia means that one consent given from the patient, that is okay. If patient is sound mind, have to. And medical superintendent role comes when the patient is not in sound mind state condition or he is not having any other attendant.
No sir, no. Consent is a contract. In contract, all the persons should sign. One is the hospital where the patient is being admitted and operated. Second is the surgeon or doctor treating. And third one is patient. Because for every responsibility, every work, doctor cannot be responsible. Hospital services are also given to the patient for which only hospital is responsible. So the signing authority should be 3 persons, whether patient is sound or unsound, manager of the hospital or CMS, the person authorized to administer the hospital should sign over the consent.
So I think now it is clear that the patient should sign on the consent and there should 2 witnesses and as well as the sign from the hospital administration in the form of superintendent or manager.
If there is a consent in court and the medical superintendent has not signed it, if a consent, if it is presented in court and the medical superintendent has not signed it, will it not be admissible or will there be some error back in the consent?
No, it will be admissible. It will be admissible.
So legally there is no requirement of a medical superintendent.
But legally there is no such requirement.
Only the doctor, the patient and the
There
witness.
is no such requirement that medical superintendent should sign. What I understand is that the consent, on consent paper, the signatures of either the patient or his attendant should be there, and the concerned doctor that he has informed all the particulars to the patient.
I think again there is a dilemma over the legal aspect and the usual practice, as Dr. Bhatia said. Sir, any comment?
Actually, whenever there is litigation in the court, only the documentation will prove who is responsible and who are the parties. If there is no responsibility taken by the hospital and hospital is made the party, then hospital can die by jhaak sakta hospital कि I was not the party of contract. Although the patient was treated in the hospital, but there should be some documentation where the responsibility of the hospital can be fixed.
Sir, I would like to add that even if there is no signatory from the side of the hospital, but since the doctor is serving in the particular hospital, therefore the liability of the hospital is the hospital is also vicariously liable. Yes. The hospital cannot say that since there is no signature of any of my representative on the consent paper, therefore I am not liable. It cannot say like that. Hospital is very much liable vicariously.
I would tend to agree with Dr. Bhatia. Many difficult situations arise, not here, but it could arise anywhere, especially in smaller clinics. Clinic for the owner may say, I am not responsible for it. I am not a party to it. So to be on the safe side, we should have the manager of that hospital also sign that consent so that he becomes a party to the contract and he feels that he is a party to the contract. We will proceed further. Question 2, how to disclose the information that an unfavorable event of bile duct injury has occurred or some complication has occurred. Tell that, what should we tell to the relatives and to the individual? Or should we keep it to ourselves for how long? Yeah. I'll ask Dr. Rati.
What is more important than one should pick up the complication very early. So post-operatively, you must vigilant in a patient जिसमें आपको लग रहा है कि difficult हुआ है, कोई problem है, take round after 4 hours, all that, and keep in regular contact. Then comes कि how to tell the attendant or how to expose that. कि what is better कि tell 2-3 things. Straight away, don't tell कि I am injured या this complication हुआ, it will be bad. It may be some sort of complication, it may be some minor complication, there may be leakage from the liver bed, it was a difficult, or there may be infection possibility really not ready to accept within 24 hours. If you are detected after 2-3 days, then you can see. If you detected on the next morning there is bile coming from your drain and you have to displace and it is more than 100 ml. And third thing, what is the vital of the patient? If suppose patient is not having tachypnea, no tachycardia, blood pressure is normal, patient is everything, so nothing to worry. If there are complications, then you have to first expose in 2-3 things. It may be this, it may be this. Let us investigate first us, then we will further inform you what happened wrong.
What to document in the case sheet after one finds that there is a bile duct injury? What to mention in the case sheet?
Again, if you showed after the investigation and all parameter ki there is some mistake has been done or when unwanted thing has happened or injury etc., then it is better to re-evaluate your case sheet. If anything was left the time of admission, the consent form completion, first re-evaluate all things. And also you can mention in operative note it was the difficult cholecystectomy because of what reason? Because of the bleeding complication, artery anomalous, cystic duct anomalous, or any other, yeah, frozen, all complication as our the literature we know all that, then your operative note should be strengthened enough before your case sheet or your BHT goes to in any forum, in any proceeding, any legal, then it should be, must be re-evaluated by the operating surgeon and the hospital as well as.
Any contribution in this aspect from the audience? Any suggestions? Any comments?
Sir. There was a case in All India Institute of Medical Sciences in which consent was taken and consent for lab poly was taken. And while taking consent, it was written from the patient side that any additional procedure can be done if required during surgery. Lab poly was difficult and the case was open. In open case, there was CBD injury. And that CBD injury was observed during surgery. Then choreography was done. When patient became conscious later on, she found that there was stitches all over abdomen. So she went to the court and the case went up to the Supreme Court. Supreme Court observed that consent was taken for additional procedure. So this open cholecystectomy was part of the additional procedure, and this cholecystectomy also was a part of the additional procedure. No separate consent was required. In surgical notes, clear-cut it was written that such and such procedure was difficult, was converted to open, and in open this CBD injury was found during surgery, and so this procedure was done. Ultimately, the doctor and All India Institute team was exonerated and there was no penalty. So this is the take-home message: document everything. If your documentation is strong, you will win even up to the Supreme Court. Whatever you say something to the patient attendant, always document. And whatever you document, always tell to the patient. Documentation is the only defense in the court, from district court to Supreme Court.
Actually, just a comment here. If anything goes wrong, then always become extra alert and don't take it otherwise कि सब हो जाएगा, मैनेज हो जाएगा. बहुत छोटी, जैसे अभी प्रीवियस डॉक्टर अनुज एग्जांपल दे रहे थे कि वो लूज होके ट्रोकार अंदर छूट गया एंड सिस्टर मेंशन दैट. तो इफ सपोज जस्ट डॉक्टर अनुज उस टाइम एक सीएम का शॉट ले लेते तो आगे के सारे कॉन्सिक्वेंसेस खत्म थे कि एक्सरे कराया, वो कैंडिडेट बता देगा, वो अलग है, सेम हॉस्पिटल में मैनेज हो गया. तो अगर छोटी भी चीज कोई आ रही है फील्ड में कि भाई ये चीज रॉन्ग हो गई, सिस्टर ने मेंशन किया आपके, एंड योर फर्स्ट असिस्टेंट इज वेरी इंपॉर्टेंट. If your first assistant is saying, no, I am not happy with this, yeah, there is this, always pay attention to that and revise your all documentation and correct it if there you found any fault there. It is very important.
So, definitely our resident, please note the importance of documentation. Documentation is very clear and concise. Documentation is very important. That is the only thing which will protect you from the legal point of view. That's why we emphasize so much for proper documentation.
किसी भी कोर्ट में किसी भी तरह से आप लिटिगेशन में बच सकते हैं. 5 सूत्र हैं, 5 points. Number 1 is documentation. Number 2 is communication. Number 3 is documentation of communication. Number 4 is communication of documentation. And number 5, preservation of document. These are the 5 points. इसमें आप कभी भी कोर्ट में हार नहीं सकते.
Yes, I fully agree. Please note. Questions in junior colleagues, the residents. Question 4. Whether to treat such a patient? If treat, then who is eligible for treating a hepatobiliary surgeon or a surgical gastroenterologist or a general surgeon with documented experience in such cases or a general surgeon with no documented experience of such cases? So this is an ethical issue. So I'll ask Dr. Rathi to address this issue. I have asked CMO, but he is not here.
Actually, third one is obviously out. General surgeon with no documented experience of such cases is already out. The comes with the between the two. The first one is okay. Hepatobiliary surgeon or surgical gastroenterologist is no issue. He can operate. General surgeon with documented experience, if he is a part of a one team long back. Suppose now he is doing practice, but he has worked in a particular GI surgery unit during time of his postgraduate senior residencies or any other, then even he can do that very well. Just you have to prove any such type of inquiry, such coming to the any panel or any inquiry set up by the government, then that inquiry committee first assess this, कि he was the right person to further handle it or not. So if somebody is degree holder, then no issue is the, but then comes the MS, can do the hepatobiliary work or not. If he has a good experience and is the good work with the hepatobiliary or gastrosurgery unit and he can document, then he can prove it, then he can do, in my opinion.
सेम सेटअप में जहां सीपीडी इंजरी हुई है, सेम सर्जन द्वारा ऑपरेट करने से लिटिगेशन फैक्टर बढ़ेगा. So better an experienced person or MCH person should operate. If facilities are not in that institution where that has been operated, the patient should be shifted to the higher center.
Thank you.
I just want to add something. After completion of this MS degree, I will request all postgraduates, please go to some centers. Or there are some short-term fellowships, 3 months, 2 months, there hepatobiliary work is being done. Like I have done ISPBA fellowship in Gangaram for 3 months, and then Rajiv Gandhi Cancer Institute for 1 year. So some certificate course where all these works are being done in polio cases. So these certificates will naturally help and they will increase or enhance your skill also. So these certificates and training from these centers will help in litigation, and you are performing lab colleague. If you really want to do lab colleague, so you have to learn CVD injury also. Thank you.
Actually, I think question, the second part is general surgeon with documented experience in such cases. In my opinion, sir, he can perform. मतलब अगर suppose we inquire the matter and this comes कि suppose हमारे यहाँ डॉक्टर विशाल सक्सेना है, he is a general surgeon, he is I think short term SRC from the Chandigarh PGI, no fellowship, and he is doing lot of cases, lot of experience, and previously all general surgeon used to do all hepatico-cystectomy, all that. But आप पर prove करने का होना चाहिए कि मैंने ये ऐसे किया हुआ है. And Dr. Dheeraj has mentioned, if you have fellowship, that is well and good, that is very good. That thing.
The general surgeon should have documents proof that he has done number of surgeries in that institution. There should be documentary proof from that institution where he did the work.
So the importance of logbook is there.
Yes. Is there any importance of some maintenance or maintaining logbook during MSc?
Yes. If you maintain your logbook, that is a document to support that you have done so much of work, and they were all there was no complication. So logbook is very important and that should be maintained.
Sir, suppose the matter goes to court. Now I have a couple of questions. One, if we say that the general surgeon with a documentation is only eligible, then what is the document that is admissible in court? Secondly, is a fellowship admissible in court? And till when are we going to say that a general surgeon is not allowed to do this procedure? कि ये फॉर एग्जांपल ब्लैडर स्टोन है तो वो यूरो सर्जन ही कर सकता है क्योंकि उसका डोमेन जनरल सर्जन नहीं कर सकता. Sir, if it goes to the court, sir, specifically to Mr. Pravin sir, क्योंकि हम कोर्ट का पर्सपेक्टिव एक बार जानना चाह रहे हैं. What document, what degree is वो at कितना सुपर स्पेशलाइजेशन तक जाए?
सर इसमें कोर्ट का जो है बड़ा क्लियर है that if you are going for a procedure, इसमें जो कोर्ट का व्यू है that is very clear that if you are going for a procedure, then you must have necessary skill for that. If you are not having necessary skill, then the court says that the concerned professional will be held liable for negligence. So it is having necessary qualification, having necessary skill. That is what court says.
तो necessary skill का क्या माने? For example, a fresh pass out.
Necessary skill means that if I am going for a general surgery, so then I must have the qualification for qualification of a general surgeon. If I am going for a eye surgery, then I must have qualification for qualification of an eye surgeon.
And sir, what about the surgeries which are common between two specialties, a general specialty and a super specialty? तो कुछ surgeries होती हैं सर जो common होती हैं, general surgeon भी कर सकता है, super specialty.
Then it is not the individual to decide that whether he should go for particular kind of surgery or not. If he is having, if he feels, if he thinks, if he is having necessary qualification, necessary skill, then he should go ahead. Otherwise not.
Sir, my saying, still there is a case pending in the CM office. One general surgeon operated for TURP and there was a complication and there is litigation in the court and medical board has been constituted in which that general surgeon could not prove still he was having experience of doing TURP because at that time when I did, there was no course curriculum of TURP or DEPCOLI. So whatever is taught in the postgraduate, if that is within your practice, then you can do that. I cannot do TRP because I have no experience, I have no course curriculum at that time. I can do LabColi because later on now, at that time there was no course curriculum LabColi. Now, around 10 years back, I took training in the Institute of Medical Sciences, I took training in the Agra, and that center should be recognized by either the Medical Council or the Government of India. It is not that in any institution, there are multiple centers, they are giving training for 3 months, 2 months, 6 months, but they are not recognized by the government or the Medical Council. That certificate will not be enough in the court to prove that they can do that. So fellowship, if done from a center which is recognized by Medical Council or the government, only that is worthy in the court of law.
Is fellowship equivalent to a degree? That is my question.
Pardon?
Is fellowship equivalent to a degree?
If fellowship is awarded by a center for which that center is recognized by the Medical Council or the government for that purpose.
सर जैसे बहुत सारे corporate hospitals fellowship और short term courses कराते हैं.
If that is not recognized by the Medical Council or the government, then that is not in the court of law will be proven that they are entitled to do the above.
Despite being a very big brand also.
Because in this case also in CM office, that fellow submitted fellowship and that is not recognized.
कुछ सर बहुत बड़े brands हैं.
They are doing?
जैसे गंगाराम हो गए, ये सब हो गए. They are also providing, but they might not necessarily be registered.
Gangaram is a DNB center recognized by the government. So in that pretext, that fellowship can be recognized in that pretext only. If you start fellowship in this medical college, if you start some training of LabColi or TURP short term in this medical college, then that will be recognized because your medical college institution is recognized by the government as well as the medical council.
Suppose if any course is not recognized, then obviously it cannot be said that the person who has acquired particular qualification, that he is having necessary qualification, cannot be said.
So best protection is the
recognized fellowship, MCA. Second best would be the logbook, that he has already done so many cases without complications. So every consultant should have his logbook along with him, probably, which enumerates all the procedures which he has done without complications. So that would be the second level of protection.
सर आपने कहा कि the course has to be registered. I am not sure कि जब कोई fellowship registered and recognized. सर जब कोई fellowship कोई institute अगर fellowship कराता है, I am not sure कि वो उस course को register कराता है किसी भी statutory body में. So sir there is a contradiction between what you have said and what Bhagia sir said. आपने कहा वो course particularly register होना चाहिए. Sir कह रहे थे कि if the institute is registered in giving some other degree in that particular area, then also we can assume that the short-term course is registered. Sir, legally इसमें से कौन सा सही है?
Legally, I think that it is the recognition of the particular qualification by the government that matters. It is not of any particular hospital.
So it means sir मान लीजिए मैं इसलिए कह रहा हूँ सर क्योंकि बड़ा pertinent question है. We have this and a lot of PGs and me including we have this कि अगर हम किसी ऐसे जगह पे जाके fellowship कर लेंगे तो वो register हो जाएगी. For example, I have a MS course running in my college. मैंने एक 2 महीने की minimal access training का short term course शुरू कर दिया जिसमें मैं lab पोली सिखाता हूँ. I have not registered this specifically in the medical council in the National Medical Council. But I am already running a MS course. So will this short-term course be?
I don't think. It's my personal view.
Actually, थोड़ा सा इसमें ना जैसे आपने कहा कि मैं मतलब आप किसे सिखा रहे हैं? अगर आपके यहाँ MS registered है और lab college the now gold standard, तो lab college the part of that MS training. After that you are taught to whom? मतलब I think there is no department in the any institution, any medical college where the lab poly is not being done now.
So let's assume it is lab CBD exploration or lab gastrojejunostomy.
Then your part is जैसे lab CBD exploration and the lab gastrojejunostomy comes to the advanced laparoscopic surgery. So first, how you will prove that you are trained enough in the advanced laparoscopic surgery? There should be AI surgeon unit. Then you can say that we are trained in the advanced laparoscopic surgery. That is why we give this training to this particular field. Any other house opinion or any panelist who want to say sir anything?
Dr. Maurya in Agra Medical College is giving short-term training in medical college itself. I don't think that training certificate course would be taken permission from the medical council. Regularly, when he was in medical college, he was giving certificate course of 1 month or 2 months.
Actually, NMC encourages us to conduct short-term courses, value-added courses. So, take-home message is for my junior colleagues, the residents is, don't try to repair the damage done. Send it to the senior colleague or a center which is recognized for hepatobiliary surgery. Question 5. When is actually the doctor at fault legally? Which means he has done the surgery, bite-up injury has occurred. Now, this could be classified into 3 aspects. That is a complication of the procedure, but it could be a complication, it could be an accident, or it could be a negligence. Is it a criminal negligence? When does it become criminal negligence and when is it negligence? When he has taken all the precautions, done the surgery and this complication has occurred. So should it be, when it should be taken just an accident, that it just occurs, the complication it just occurs, we can't help it. Second is that there has been some carelessness on the part of the operating surgeon. If he was taking all the precautions, probably the injury won't have occurred. The other side is that literature says we have not been able to bring down the rate of injuries to 0. Some injuries will occur. So where to prove what type of negligence? What will be the court's view on this?
So in this situation, the question is of negligence. Negligence on part of medical professional. So the settled law, as laid down by the Honorable Supreme Court over last 20 years, is that if the question of medical negligence arises in two situations. One is when the concerned person, the concerned professional, he is not having necessary qualification or skill. First, then he will be assumed to have committed negligence. And secondly, if he has not taken reasonable care of the procedure, then it will be assumed that the person concerned is guilty of medical negligence. So only in these two situations that a person would be, or a professional would be held liable for medical negligence, otherwise not. But in case he has taken, if he can show to the court, if he can show to the court that he has won as per general and approved practices, then he will not be guilty of medical negligence. And secondly, if he shows to the court that that the incident happened despite taking reasonable care and caution, then also he will not be held liable for medical negligence. So in these two situations, he will not be held guilty. These are the two defenses which are available to him in a court of law.
The take-home message for the junior colleagues is if they are not trained to undertake the surgery for an injured wild duck, they should not do it, because then they can be held responsible, they can be tried for negligence, because they do not have adequate experience to undertake the surgery of repair of wild duck.
My comment, sir. One. Bolam test is the test to assess the negligence. That is well accepted in the court of law up to Supreme Court. What is this Bolam test? The similarly qualified person in similar situation, what he could have done or what he has not done, that is the parameter of the negligence. If I am a general surgeon and I am doing some surgery that had some complication which cannot be managed by me, or which in a better way could have been done by a MCH gastro, so both cannot be equated. My negligence will be counted only if other general surgeon could have done that thing or could not do that thing which was required in the similar situation. Similar situation means कोई सर्जरी सरदना में हो रही है, कोई मेट्रो सिटी में हो रही है. सरदना में मैं क्या कर सकता हूँ, that cannot be compared with the Meerut, that cannot be compared with the Delhi. तो similarly qualified person in similar situation क्या करता या क्या नहीं किया, that is the parameter for negligence in Bolam test.
Suppose if two surgeons are operating together and there is the injury, does this test nullifies? What does the court say? What is your experience?
No, sir. If the both are similarly qualified, then it cannot be said that the better could have been done by MCH gastro.
My point is that another surgeon of the same qualification in the same settings, what he has done must be done by the other also. That is the thing. That is
Yes.
Suppose if two surgeons are operating together and a common vital injury occurs, then what is the scenario? Does this test still holds true?
Yes. Whether two operating or three operating, the similarly qualified persons were there. There was no gastrosurgeon. So it cannot be compared that if there would have been a gastrosurgeon, he would have done better. It cannot be compared.
Sir, there will be no medical negligence in this case.
Yes. Yes.
अगर दो सर्जन ऑपरेट कर रहे हैं तो क्या ये मेडिकल नेग्लिजेंस में आएगा मिनिस्टर?
Sir, then it would be a case of collective negligence. I understood your point, sir. What you are saying is that if two surgeons have performed the surgery together, and if some mistake has happened, some negligence has occurred, then what would be the situation? So, my perspective is that in case this happens, then it will be a case of collective responsibility.
So whether it will be considered as a negligence or it will be considered as a complication? Both
things are different. Both things are different.
Both are different, sir.
Both things are different.
CPD injury is a known complication.
In case of complications, the professional will not be held liable. But if there is a negligence, then the liability will be there.
If the complication has not been recognized by the operating surgeon timely, then it is negligence.
The operating team has not paid enough attention to diagnose it early and manage it professionally.
सर राखी सर अब गॉल ब्लैडर सर्जरी में बहुत सारी नई चीजें आती जा रही है, जैसे कि रोल ऑफ इंट्रा ऑपरेटिव एंजियोग्राफी एंड वो. सो आर दीज अ स्टैट्यूटरी रिक्वायरमेंट एंड व्हेन शुड दीज बी कंसीडर्ड? कोई कल को कोई दूसरा बंदा कहे कि हम तो इसमें एंजियोग्राफी करते ही करते, इन्होंने नहीं किया इसलिए गलती है. व्हेन टू डिसाइड कि दिस प्रोसीजर और दिस एडवांसमेंट इज नेसेसरी फॉर दिस ऑपरेशन.
पर वो दूसरा बंदा, जैसे सपोज हायर सेंटर डॉक्टर, you mean to say कि suppose complication has been done by us, you here, and you send the patient Max or Saket, and they will told that कि we do like this, ऐसा होना चाहिए. I think usually this is not the tendency among the doctors. Usually, or if in current scenario this happen, so I think this is not very much valuable in a court or any future consequences. It's not like that.
This is not part of standard care. This is not part of standard care. Say, like a CPD injury, like it is happening to probably a vascular injury occurs. Vascular anomalies should be detected pre-operatively by doing angiography. So far, it is not standard of care.
Sir, the question is, मान लीजिए ये चीज कोर्ट में है, and हमने अपनी तरफ से ये justification दिया that a majority of surgeons are not frequently doing this procedure, and then the patient comes up or the patient's representation comes up that this is the paper which is clearly showing कि जब इतने patients में ये process किया गया तो incidence of injury कम हो गई. Then also can he not prove कि इन्होंने ये क्यों नहीं किया? Sir, for example,
it comes up in one publication where probably 100 cases done in some center. They did angiography and detected the anomalies. So their safety factor is better than those who are not doing. But this has not become a standard practice.
Actually, I think it's some sort of hypothetical. What happened कि at that time where you get operated, तो जो patient है उसे भी तो पता है किस center में मैं operate हो रहा हूँ, वहाँ की facilities क्या क्या है. आपने consent में inform तो किया ही है ना. I have such type of facility. अगर suppose injury होती है तो मेरे पे gastro surgery की facility नहीं है, या मेरे पे gastro surgery की facility है, अगर होता है तो I will refer. Actually, all this depend on the again thing will go to court, and final will be the court decision what the that honorable judge thinks it should be considered or not. In my personal opinion, these usually court is favorable unless until ऐसा negligence नहीं है कि आपने CBD injury करा और आप अपने फार्म हाउस चले गए, रिसोर्ट पे चले गए, not bothering कि हाँ पेशेंट को रेफर कर दो, फ्लूइड लगा दो, ये मैनेज कर दो, कोई डॉक्यूमेंटेशन नहीं है, आपका कोई एफर्ट नहीं है उसमें, then negligence comes. If you have proper documentation, you have taken proper care, you have put the note yourself, your proper communication and mention कि I communication to gastrosurgeon and he advised so and so refer to patient, then I think most of the time you will be, court will be in favor of you. Anything sir you want to comment?
Sir, like Dr. Krishna is saying, any procedure will be standardized when they come into the normal surgical textbooks. when it is available in all the surgical textbooks that this procedure, this step, this thing has to be done in the surgery, then it will be standardized. Because when we go to the court, we place our standard textbook, that these are given our standard textbook and we do like it. One paper, two paper, any research will not come to as a normal standard until it has been replicated in our textbook.
When is actually the doctor at fault degree, and what is the hospital's role? What is the hospital's role? An inquiry committee looking for, and what is the court looking for? What is the hospital's role? Coming to the hospital's role.
Sir, hospital role come to the what facilities. Each hospital is having all facility for that procedure, and it is registered legally. And that procedure that has been done is, if he is having all facility to done that procedure, then hospital can be saved.
Sir, I would like to add that so far as the question of negligence comes, so if there is a negligence, then it is the doctor, concerned doctor, and concerned hospital as well. It will be held liable.
Both are parties. It is part of the contract of the three parties: patient, doctor, and hospital.
Because the doctor, medical professional is serving at the hospital, so hospital cannot say that I don't have any liability.
Hospital has two roles. Number one, preservation of document is the role of the hospital. Whenever document is required, hospital has duty to produce that. So, maintenance of the hospital record, it should not remain incomplete. Most of the doctors go without documenting all the things and patient is discharged. So it is a duty of the hospital to get it complete, case sheet should be completed, number one. Number two, the hospital staff should be qualified, whether OT staff or ICU staff, they should be having qualification, otherwise hospital will be also liable.
सर प्रवीण सर से सर सपोज मेरा एक 10 बेड का हॉस्पिटल है और मैंने एक जनरल सर्जन को जिसके एक ऑथराइज जगह से डिग्री है चेक करके उसको रखा माय होल स्टाफ इन द ओटी एवरीथिंग इज देयर एंड स्टिल समथिंग लाइक दिस हैपेंस नाउ व्हाट इज द रोल ऑफ द हॉस्पिटल एंड स्टिल उसकी वाइकेरियस रिस्पांसिबिलिटी आएगी नहीं आएगी कैन द हॉस्पिटल जस्ट नॉट से कि मैंने तो बंदे को रखा था उसके सारे डॉक्यूमेंट्स चेक किए तो तब हाउ एम आई रिस्पांसिबल
The vicarious liability of hospital will come because ultimately there is a contract of service between the hospital and the concerned doctor. So if there is a negligence committed by the medical professional, then the liability of the hospital will also come.
Sir, a number of general surgeons are operating at hospitals where they are on a contractual basis. जहाँ पे वो अपॉइंटेड नहीं है, फ्रीलांसर की तरह काम कर रहे हैं, they are going and operating there. In this case, suppose the hospital says कि तो contractual basis में है और हमने जो साइन किया है उसमें साफ-साफ लिखा है कि आपकी liability आपकी होगी. Can the hospital still bail out?
It cannot.
Even if it has been written between these two.
Even if it is written that there is only contract, short-term contract regarding service of the particular doctor. So it cannot, there will no absorbing of responsibility of hospital.
Suppose sir, अब हम surgeon की तरह नहीं hospital की तरफ से बात करें. So what should a hospital fellow who's running a short clinic or a hospital should keep in mind to save themselves?
I would say that these are the professional hazards that come. So one has to be ready and things. There cannot be 100% safe.
I think CMO sir has come. Maybe he was sitting here, where they have said to me, we could have taken his opinion if he was here, but the administration is looking for. So we proceed to the next question. To agree to go to court, should we agree to go to court or settle, try to settle this case out of court?
Sir, regarding settlement of the cases, my personal perspective is that if there is no fault and you have been unnecessarily dragged in the court, then you should fight it out. Instead of going down, you should fight it out. But if you also feel that there is some kind of negligence, there is some kind of fault on my part also, on part of a medical professional also, then it is better to say.
Any comments on this from the audience? Any suggestions, comments, questions on this?
बिल्कुल ठीक इन्होंने कहा कि अगर you are very much strong that you have not done any negligence, your documentation is complete, pre-operative, per-operative, post-operative, and there is no fault finding record, so you should fight the court. One thing. Second, the new Consumer Protection Act that has given settlement, you can say it out of court whenever a petition is filed in consumer court. Now there is a new provision. Both parties can ask the court that we want to settle it out of court. Then there is a mediation cell in which two persons from that mediation cell will be appointed to hear both parties, and if there is any settlement between the both parties, then that will be submitted in the court and that will be final. And that final judgment cannot be challenged in High Court or State Commission or National Commission or Supreme Court. That will be the final. Whether on payment basis that settlement has occurred or without payment basis, that depends on case to case. But there is a provision now in new Consumer Protection Act.
Thank you, that's a very good piece of information. Next question. Does the scenario change if the patient dies?
Sir, scenario definitely changes. Death occurs, then the scenario changes. Because there will be a lot of allegations, there will be a lot of questions, lot of allegations. So scenario changes. Therefore, the question of not only civil negligence, but criminal negligence will also arise, which is very difficult to defend.
Case becomes very serious if the patient dies, especially if this biliary entry anastomosis has been done, and that ends up in a severe peritonitis and fatality. Case becomes very serious. So that's the point one must keep in mind, not to attempt such procedures. One doesn't have enough experience in this, or a certified course done.
Can I say something? What I want to suggest, if a patient dies after treatment in the hospital, the treating doctor should insist that a postmortem should be conducted. And he should put it in record that he suggested that postmortem should be done, and let the attendant of patient deny that postmortem is not to be done. That will ultimately go in his favor.
Very correct, sir. It's a very important that we must document, we must ask for the postmortem and document it, and let the relatives refuse the postmortem.
Can I add one comment? Whenever postmortem is advised, then postmortem should be done. You inform the police, send the memo, advise postmortem, hand over the body to police, then let the attendant or police decide whether postmortem will be done or not done. Never become party between the attendant and the doctor. They should not become party whether postmortem should be done or not done. If they deny postmortem, that should be denied to the police. Later on, the attendant can say, I had not denied, So better send police memo for postmortem, and police should come, take over the body charge, and if they don't want postmortem, then let the police and the attendant decide. You never become the part for not deciding postmortem.
That's very important information.
Sir, suppose this matter is in court and the doctor is able to produce a document which has the patient's attendants refusing for an autopsy. How does this help the case of the doctor? ऑटोप्सी के लिए मना कर रखा है अटेंडेंट्स ने, इससे डॉक्टर को क्या फायदा होगा उस केस में?
ऑटोप्सी के लिए अगर मना किया है, डॉक्टर को ये फायदा होगा कि अगर उसमें नेग्लिजेंस कोई साबित होती है तो चूंकि पोस्टमार्टम हुआ ही नहीं है तो वो कैसे नेग्लिजेंस साबित होगी। दूसरा, अगर अटेंडेंट ये कहता है हाँ ऑटोप्सी के लिए मैंने ही मना किया था, कोर्ट में इस बात को एडमिट करता है, तब इस बात की इंपॉर्टेंस है। अगर वो कोर्ट में कहता है मैंने मना नहीं किया था और मैं फोर्सफुली मेरे से ये साइन कराए गए, तब फिर केस पलट जाएगा।
I would like to say that in case patient dies and a case is registered, then postmortem is done. It is not the option of either the relatives or any other person that the postmortem is done. If the case is registered, then postmortem is done.
Sir, but a number of times the case is not registered then and there. It's an afterthought that they put in a legal point.
Case is registered then and there. Then and there is within a short time.
How much short?
Autopsy
how much that depends on I mean there is no fixed criteria for that.
Usually some patients बाद में ये चीज उनके पॉट आता है, बाद में कभी-कभी after 6 months बाद ये is there any criteria, time criteria?
No, there is no time limit.
One more message: if body is sent for postmortem, never give death certificate. Never give death certificate if body is sent for postmortem.
Sir, suppose we are at a tertiary care center. We are not the people who are doing the injury as say per se, and we are at a tertiary care center and the patient has been received by us, and basically the patient is dying in our setup because of the complications that were possibly there or because of our operative issues or anything. What is the role of the tertiary care people in such an issue? They may be the primary doctors also and the higher center also, or they may be just tackling a case that has been referred to them from another institute, and the patient is dying in that setup.
I think again comes the issue of documentation. At your center, at the time of admission, what was the vital parameters and all that thing of the patients, and if you have operated patient and treatment, all that, how much you document all that. So again the role of documentation come in this scenario.
If it is a medical legal case, then always send the body for postmortem. Whether you know the cause of death, even then you send the body for postmortem, it is a medical legal case. In non-medical legal case, if you have any doubt about the cause of death, then send the body for postmortem. If you are issuing the death certificate, means you know the cause of death, then there is no need to send the patient for postmortem. And if you suspect that this can go for a legal action, then also you should send the body for postmortem.
What is a medical legal case?
Medical legal case, if there is a roadside accident and that was managed at the primary center, then after it was sent for the higher center and then come to this also institution and laboratory was done, then also you have to send the body for postmortem, although you are knowing the cause of the death.
Or bile duct injury, when does it become a medical legal case? Bile duct injury which has occurred during cholecystectomy, when does it become a medical legal case?
That become medical legal only if मरीज के अटेंडेंट हल्ला काट दें कि यहाँ पर नेग्लिजेंस से मरीज की डेथ हुई है, तब आप इसका पोस्टमार्टम करेंगे.
Who decides that it is a medical legal case? The doctor, the institution, or the police?
Police.
If the situation is that the police has arrived, then you send the body for postmortem. If you suspect that the patient हंगामा करेगा और ये केस करेगा, तब भी आप उसका पोस्टमार्टम कराएं. Then doctor and hospital has to decide ये तो आपको सूंघना है, वो सूंघ से पता लगाएंगे कि ये मरीज किस तरह जा रहा है। सेफर साइड इज गो फॉर पोस्टमार्टम।
Medical legal postmortem is ordered by the administrative authorities, isn't it? Medical legal postmortem is ordered by the administrative authorities. Supposing
it is not a medical legal postmortem. It is not a medical legal postmortem.
It is not a medical legal.
No, it is coming under jurisprudence.
Sir, suppose we are receiving at a tertiary care, we are receiving a patient who has been complicated, say, by a ERCP procedure. And now the patient is coming to us in sepsis. We do some procedure and the patient dies. And in such cases, the primary hospital has a very good hold on the psyche of the patient. And the patient's party choose to press upon you the charges. Then till what extent should you go on saving your colleague who was an ERCP fellow?
A complication is occurred in the ERCP. After ERCP, patient comes to the hospital which is treating that patient. Patient send that patient for ERCP to remove CBD stone, and during ERCP complication has occurred, sepsis has occurred. So, what is the liability? Or supposing that hospital takes up that patient for surgery in next 48 to 72 hours, does a cholecystectomy, and patient dies of sepsis, not of cholecystectomy. That is our opinion. But the other party will say that it has died because of cholecystectomy complication. So it becomes a complicated situation. So what is the liability of each party in this? That's what
I think Dr. Krishna is mentioning how we have to save our colleague that who has done that complication. So it is the simple answer that if you are safe, think you are safe, then try to save your colleague. If you think you are in danger or you may become liable for that, so don't try to save. अगर आपको लग रहा है कि मैं सेफ हूँ और मैं ऐसे हेल्प कर सकता हूँ किसी की, तो always help to your fraternity, always help to your colleague, and same perspective in the various inquiry committee comes to us कि हमें लगता है कि हाँ ऐसे ऐसे ये एविडेंस हैं, हम पे कोई इफेक्ट बट नहीं करेगा कि बायस डिसीजन है, then otherwise we can't do that. Anything?
First you save your own skin, then save the other fellow. And your own skin can be saved only when the patient arrives. You tell them the status of the patient, vitals of the patient, and what is the procedure you are going to adopt, what are their complications, what are their success chances. So first you save your own skin, then save your colleague.
Sir, may I ask one question?
Yes.
Sir, what is the difference between negligence and complication? Because something is written in the book that this may be the complication. When the court will say that it is negligence on the part of surgeon, and I will say it is known complication, suppose incisional hernia occurs after a surgery. So whether it will be taken as a negligence or it is a complication of a surgery. Or similarly, CBD injury is known in cholecystectomy. So is it a complication of that surgery or is it a negligence on the part of, because you are punishable in negligence, not in complication.
If there is complication and that has been recognized timely by the operating surgeon, then it is not negligence. If the recognition of complication is delayed or has been missed by the operating surgeon, then it is negligence, number one. Number two, for negligence, already I have given one definition of Wolff test. Similarly qualified person doing in similar situation the thing which other person would have done, that is not negligence. It is not a question of higher person would have done, the MCH urology would have this thing and general surgeon is doing this thing, that is not comparable. The similarly qualified person in similar situation क्या करता जो उसने नहीं किया या जो नहीं किया जो उसे करना था, that is the parameter of the negligence. These are the two things about negligence.
I would like to add that what will be seen is that whether the medical professional, concerned medical professional, he has taken due care. He has taken due care in all respects or not. If he has taken due care, and despite that complication occurs, then it will not be covered under medical negligence. But if he has not taken due care, then the case will be covered under medical negligence.
What would constitute a criminal negligence in these cases? I've asked Dr. Rati, what would constitute a criminal negligence in such cases? Dr. Vishwanath, what would constitute a criminal negligence in such cases?
Civil injury. Which case?
In civil injury case which has occurred as a complication after cholecystectomy, when does it become a criminal negligence?
For criminal negligence to be decided, Supreme Court in Jacob Matthew has suggested to take opinion of the medical board. Whatever opinion is given, because neither the court nor the other person know about the medical literature. What is written in the medical literature, what are the other complications or negligence factors. Whatever court is recognizing that a negligence, that can be a complication. So this opinion will be given by the board, medical board. And medical board will assess the negligence on the basis of Bolam test. It is not the self-designed parameter. It is a Bolam test parameter on the basis of which negligence will be characterized. On the recommendation of only medical board, the negligence will be registered.
Recently, cases have occurred where patient has died after surgery and the doctor has been blamed for attempted murder and put in bars, or was accused of murder by police and she committed suicide.
There had been a hot debate in all the media, the print media, electronic media, and first mistake done by the administration was they had registered the case in 302, which cannot be. That at the most should have been registered under 304A, and that too after taking the medical board opinion. That's why, and moreover, Gunda party and all, they harassed the hospital, and the lady doctor was very sensitive, so she committed suicide. So it was an administrative murder. It was not the negligence death.
302 तो उन पे लगनी चाहिए फिर,
तो लगनी ही चाहिए थी.
Is there a difference between a civil and criminal cases in such situation? Which one can be lodged by the patient, and what should be the first thing the surgeon and the hospital do? Last question.
There is a difference between civil negligence and criminal negligence. As we discussed earlier, that the case with the liability for civil negligence arises only in two circumstances. First is when the concerned medical professional is not having necessary skill, and second is when he is not taking due care. That only in these two situations the case of civil negligence will arise. Otherwise, and so far as criminal negligence is concerned, it will be seen by the honorable court that whether in similar circumstances any other person would have done differently. This will be seen.
Sir, consumer cases भी हो सकते हैं as a third case, which would be separate from these two. Consumer protection के अंदर और आर सर वो किन केसेस में लग सकता है? अगर कोई कंज्यूमर प्रोटेक्शन एक्ट में जाता है 2019 के बाद से, हम वी आर द डॉक्टर्स कम्युनिटी इज लायबल फॉर सीपीए आल्सो. सो व्हेन इज अ डॉक्टर चार्जेबल अंडर सीपीए?
The position of consumer and the doctor is the same as it was earlier. There is no change after this new CPA. The patient can go in the consumer court, civil court, and in criminal court also.
So far as the difference between the cases of negligence under civil law and under Consumer Protection Act is concerned. So I would say that what under civil law, what is he ultimately saying is that those two situations which I have said, that whether the concerned medical professional was having necessary skill or not, checking whether he had taken due care or not. So these two type of situations will be covered in the civil law. But I will say that with the coming of Consumer Protection Act 1986, which has been subsequently amended by Act of 2019, the scope of liability has been increased much more than it is under civil law. Now the professionals will be held liable. Professionals are held liable for deficiency of service. Deficiency of service can be in any respect, whether it can be in performance, in judgment.
In new CPA, even incomplete discharge card, means discharge card having incomplete information of the treatment from admission to discharge and the past history, that is deficiency in services. The doctor is liable for that also. And second amendment is that earlier the compensation demanded was considered as a court, whether it will go to the district court or state court or national commission. Now, whatever expenditure has been done by the patient, then decides whether it will go to the district court or state court or national commission. 50 लाख पहले 1 करोड़ तक था, 50 अभी कमेंट हुआ है, 50 लाख तक का खर्चा अगर मरीज ने इलाज में किया है तो डिस्ट्रिक्ट कोर्ट में जाएगा, चाहे वहां वो 10 करोड़ या 20 करोड़ की डिमांड करे। पहले था कि इतनी डिमांड करेगा तो यहाँ जाएगा, अब है कितना खर्चा उसने किया है, डिमांड कितनी ली हो, ये अब क्राइटेरिया हो गया डिस्ट्रिक्ट कोर्ट जाने का, डिस्ट्रिक्ट कमीशन, स्टेट कमीशन और नेशनल कमीशन।
So just two more questions from my side. Sir, if a patient goes lama from your hospital, leaves against medical advice, then how does that affect your case? And secondly, what is the current legal opinion on video consents? Lama and video consent.
The consent, video consent is perfectly right if you have taken consent for the video consent. You have taken consent for the video consent. And one more consent is there, notary consent. This government approved notary, they take consent from both the parties. That is also a valid unbiased consent. And what was the next question? Lama. Lama, if you write proper notes. In Lama also you have to give complete summary of treatment you have given. If you write incomplete summary, then it is also deficiency of services. And in Lama, 2 copies should be made. One should be given to the patient and one should be received for record. Otherwise, later on patient can say, I was not given any summary of the patient. I was interested in the treatment, but the patient was asked to take away. So, in writing Lama, your responsibility decreases and you are not responsible if patient is going Lama for further treatment.
All residents, please note, whenever the patient goes Lama, you have to write complete summary of the patient's treatment findings and also keep one copy of that document. Preserve one copy of the document with the medical file of the patient for future reference.
There is one entity, discharge on request, that is illegal. That has got no legal value. Never write discharge on request. Always write Lama.
Sir, concept of video consent is still clear. Inside the video or written?
Both. Both. I have given my written consent, should be recorded in video also.
There are any more questions?
Sir, अगर हमने वीडियो कंसेंट इस फॉर्म में नहीं ली है कि वो कंसेंट है, we just recorded that हमने कोई चीज मरीज को समझाई थी, will that be admissible as we have already told the complication in court?
बिना पेशेंट अटेंडेंट की कंसेंट के कोई वीडियो रिकॉर्डिंग आप नहीं कर सकते, ये भी मरीज का फोटो भी नहीं ले सकते और ये जो हम प्रेजेंटेशन देते हैं कॉन्फ्रेंस में, सेमिनार में, हम पेशेंट की आइडेंटिटी और फोटो भी डिस्क्लोज नहीं कर सकते बिना पेशेंट की सहमति के।
The second question is, suppose we have taken a consent की वीडियो कंसेंट चल जाएगी एंड उसके बाद हमने रिटन कंसेंट ऑफ द ऑपरेशन नहीं ली है कि आगे की चीज वीडियो में है, इज दैट एक्सेप्टेबल करेंटली?
रिपीट द क्वेश्चन।
सर, मैंने पेशेंट को ऑपरेट करना है, मैंने उससे कंसेंट ले ली कि इसकी मैं वीडियो कंसेंट ले रहा हूँ, लेकिन मैंने ऑपरेशन की रिटन कंसेंट नहीं ली है, बट द वीडियो कंसेंट इज अवेलेबल विद द कंसेंट ऑफ द वीडियो, सो इज दैट एडमिसिबल?
That will work.
सर, व्हाट अबाउट द ओपिनियन ऑफ द कोर्ट?
So I would think, sir, I think that express consent would be necessary. In case you go for procedure, from consultation you go for procedure, then express consent is also necessary. This is what I think.
So video cannot bypass when it is taken.
When patient comes to the hospital, he signs a general consent. In every file, there is general consent. You don't have it here. I think in local it is there. Whenever he comes to the hospital, he signs general consent. So that probably is the express consent that he has come for treatment to that particular hospital. Is that what you mean?
That cannot be treated as a consent for undergoing the procedure.
Yes. So for procedure, separate consents has to be taken. Even for blood transfusion,
There is a difference between two consents.
For blood transfusion, there should be separate consent. For separate each bag, there should be separate consent. There cannot be one consent for 4 blood transfusion. You have to take 4 consent for 4 blood transfusion.
सर, अगर कंसेंट किसी पेशेंट को समझा रहे हैं, आपने कहा वीडियो कंसेंट हमेशा आफ्टर टेकिंग द परमिशन और आफ्टर इन्फॉर्मिंग द पेशेंट विद हिज और हर कंसेंट वी कैन टेक द वीडियो कंसेंट। अभी कुछ केसेस अगर ऐसे हो कि पेशेंट ने बिना हमारी कंसेंट के हमारे वीडियो को या ऑडियो को रिकॉर्ड कर रखा है और एनी हाउ वो केस कोर्ट में जाता है, तो क्या वो पेशेंट की तरफ से वो चीज़ परमिसिबल होगी? कोर्ट उसको वो करेगा कि हमसे तो कंसेंट ली नहीं, हमारी बिना नॉलेज के उसने रिकॉर्डिंग कर रखी है, या हमने फोन पे कुछ हुआ उधर रिकॉर्ड करके उधर अपने कोर्ट में कर दिया, whether it will be admissible for?
Sir, it will be fully valid. It will be fully valid. Consent is not necessary. Consent for recording the video is not necessary.
तो सर ऐसे डॉक्टर कर सकते हैं क्या पेशेंट?
Doctors भी कर सकते हैं. You can put it in the court.
Thank you very much. I thank all the panelists. It was a very educative session.
Thank you, sir. That was an excellent discussion on the ethical legal aspects of bile duct injury. Before concluding this panel discussion, we would like to felicitate our guests from the dais. I kindly request Dr. Nilesh Agrawal, sir, to please facilitate Dr. Sudhir Rathi, sir. Requesting Dr. Dheeraj Balian, sir, to please facilitate Dr. Deshi Bhatia, sir. Requesting Dr. Shashank Mishra, sir, to kindly facilitate Dr. Deshi Bhatia, sir. Requesting Dr. Satyam Khare, sir, to kindly facilitate Advocate Pramit Saxena, sir. Finally, I would like to request Dr. B.K. Jain sir to kindly facilitate our honorable moderator sir for the session, Dr. Y.P. Monga sir.
Thank you everyone. That was an excellent discussion, the panel discussion. Before wrapping up the conference, we'll have a last and a very interesting discussion. During the past several years, nuclear medicine has emerged as one of the most useful imaging studies in the surgical field. Not only in the diagnosis and staging, but also in the management plan and follow-up protocols of many cancers and inflammatory diseases. Nuclear medicine is a special place in several benign conditions and malignant diseases. The practicing surgeon's knowledge of nuclear medicine capabilities and advantages of each modality is very crucial. To clarify the concepts of nuclear medicine, current surgical practices, let's call on stage Dr. Avdesh Pandey sir, consultant nuclear medicine, Subharti Medical College. Allow me to quote a review from one of his patients who said, "I found sir as an excellent person, motivational and a visionary doctor. His working style is unparalleled and beyond imagination." Thank you, sir. This session will be chaired by Dr. Sanjay Prasad.
So many cases in
Sir, please.
केस शीट में नाम होता है टीम का
It's the most difficult task to be the last speaker in a conference. I have been given this task. Nonetheless, I'll try to do justice. Starting with my first lines, can I have? So nuclear medicine in surgical practice. First we'll since nuclear medicine is a field which needs a little bit of introduction to surgeons outside this campus, although we have a nuclear medicine department here. And very shortly, we are about to start our PET-CT also here. But I will not limit this talk just to a PET-CT because PET-CT mostly lateralizes to oncology and oncological practice. Nuclear medicine and the surgeon, a very diverse field wherein we almost touch all fields that the surgeon touches when he is doing surgery. So we'll try to do justice to all. What we do is we use an isotope, mostly technetium, in a gamma camera and fluorodeoxyglucose in a PET-CT. So this is an isotope which we use, which we ligand with different substances which are organ specific. Like for example, if we have to image the kidneys, technetium is liganded with DTPA. So it goes to the kidneys and we image the kidneys. It has always been a challenge to image function. Imaging, when it started with anatomy, with a trust that someday we will image function. And that is exactly what we do. So anatomically, what you see on X-ray, CT scan, MRI, angiogram are anatomical modalities. Functionally, what is the function of the organ concerned, whether it can be imaged, can be seen on a nuclear scan. So what happens is, suppose if there is a pathology, the pathology might not be localized anatomically, or it might not have caused anatomical damage at that point in time. But on an isotope scan, if
there is an uptake deficiency or an uptake increase. You can actually see that on a scan. Starting with the thyroids, interestingly, any nodule that is there, this is a solitary thyroid nodule which we see pre-surgically can be determined whether we are dealing with a malignant nodule or a benign nodule. Yes, we can, with a fair amount of precision, and this is a non-invasive test. Tests as such can be categorized into two categories: invasive tests and non-invasive tests. We have been discussing about the medico-legal complications. Non-invasive tests normally do not carry much medico-legal problems, as we have seen lately our friends facing. So non-invasively we do this test called a thyroid scan, and if we see a nodule, this is a cold nodule that we see here. If you can appreciate in the right lobe, this is a cold nodule. Cold is a non-functioning nodule which could harbor malignancy. So whether it is metabolically active or metabolically inactive needs to be seen. So we did a sesame scan and it shows metabolic activity, which means almost with a precision of 85 to 90%, we can say that the nodule is a malignant nodule. So that pre-surgical decisions of any thyroidectomy, no thyroidectomy or total thyroidectomy can be taken before invasive procedures are done. Now, iodine scans post, suppose if there is malignancy, pulmonary carcinoma of the thyroid, an iodine scan determines what is the residual thyroid that is left behind. The surgeon might say that I have taken out the whole thyroid, but there are microscopic things that are left behind, and especially if you scrape off the left recurrent laryngeal nerve, still thyroid tissue can be left behind. This thyroid tissue can be fully ablated by radioiodine in our department here. Now the next is thyrotoxicosis, which is a clinical condition, can be produced by Graves' disease or thyroiditis. In both these cases, T3, T4 will be high, TSH would be low. How do we determine that? Just by a scan, we can know that this is Graves' disease and this is thyroiditis. Ectopic thyroid, many times seen as a thyroglossal cyst. If it contains thyroid tissue, it just might be dangerous to take out that thyroglossal cyst because it contains ectopic thyroid tissue. And whenever ectopic thyroid is present and functioning, native thyroid is usually not present. Even if present, is usually not functional. A silolith, as seen on a simple technician scan. I'm just trying to show you the versatility of the radio tracer. It is not only oncology. It touches most of the fields which surgeons tread upon. So this is a parathyroid scan, and alternatively an ectopic parathyroid that we see. The patients these days, parathyroid adenomas have increased mainly due to vitamin D deficiency. That is what is our conclusion. And this also produces a metabolic bone disease which can be seen on a whole body bone scan. Like in this particular case, there could be pseudofractures also. Meckel's diverticulum containing ectopic gastric mucosa can be seen very well on a technician scan if the suspicion is high. A mid-GI bleed, a technician RBC scan is called, which we do in a mid-GI bleed, that can be seen here. A gallbladder ejection fraction. Gallbladders were discussed to the core, I will add one more tool so that medico-legally you can be on the safer side. Gallbladder ejection fraction can be analyzed. If the gallbladder ejection fraction is less than 45%, this gallbladder can merit a cholecystectomy, because many times the cases are I was surprised to see that nobody asked after cholecystectomy, the patient complains that this was not required surgery and it was done. So how do you prove that? Objective tests are required here. Cholecystography is an objective test. So this is a pre-fatty meal and a post-fatty meal. We can also do it by pharmaceuticals. DTPA renogram, just wanted to show you, this is done at our hospital here in Subharti. A congenital PUJ obstruction. You can see a PUJ obstruction on the left side. When it is corrected, you look at the graph. This is showing obstruction, and after surgery done at Subharti Hospital, see the graph comes down and both the kidneys are functioning well. Hydronephrosis from grade 0 to grade 5. Whether it is obstructive hydronephrosis or non-obstructive needs to be seen, can be seen very easily on a DTPA renogram. A non-functioning kidney, radiologists, usually, my friends are here, no they are not. Radiologists usually make the mistake of writing non-functioning kidney on an IVP. It should be written non-visualized kidney, not a non-functioning kidney. If a kidney is not functioning completely on a DTPA renogram, we usually say it's a non-functioning, non-salvageable kidney. Indirect radionuclide cysto-ureterography can be seen on a simple DTPA renogram. I'm just trying to show you how versatile it can be with a radio tracer and all these things which the surgeons face on an everyday basis. A DMSA scan to look for cortical damage or cortical scarring can be seen on a DMSA scan. It's a technetium DMSA scan. A DRCG like an MCU reflux can be seen. Why a DRCG? When to opt for a DRCG? When the suspicion for reflux is very high and MCU is normal. Those are the cases wherein a DRCG should be advised. DRCG is direct radionuclide cysto-ureterogram. So, uncorrected VUR, see how the kidney gets damaged and scarred within 6 to 8 months. A transplanted kidney evaluation, the first test to be done post-transplant is a DTPA renogram when everything is fine and when it is in campus. What happens is macro circulation can be ensured by the surgeon who is doing transplant. Micro circulation, how do you ensure that? So a DTPA renogram will be able to do on day 3 to tell you whether the micro circulation is proper or not proper. If micro circulation is proper, that means rejection is not there, and acute tubular necrosis and all those things can be actually explained on a DTPA renogram when the urine output falls. Renal artery stenosis, hemodynamic significance of renal artery stenosis needs to be seen. There could be a renal artery stenosis, it just might not be significant. So how do we see that? We do a capillary renogram, like for example in this particular case, we did a capillary renogram and the right kidney shows hemodynamically significant renal artery stenosis, which means this should be opened either with a PTRA or or if the kidney is functioning well, an auto transplant also can be thought of. A lymphoscintigraphy, lymphatics, lymph nodes can be seen on a lymphoscintigraphy. A ventilation perfusion scan. We have done a lot of ventilation perfusion scan in our own institution here during COVID times. A microcirculation scan to look for microcirculation defect or hyperperfusion in cases of diabetic foot or burn injuries. This is a microcirculation defect in the right foot. So if there is a microcirculation defect, amputation is the answer. If it is hyperperfusion, all attempts at saving the foot should be done. These days, with sunlight and vitamin D2, vitamin D evaluation, these are new things that have come up. Deep venous thrombosis evaluation on an isotope scan, just to show you the versatility of the radio tracer. A cross pelvic collateral is seen here, that we see, or a flow venogram we call it. It's a flow study, it's a dynamic flow study. A testicular torsion as seen on an isotope scan. Now coming to a viable bone graft, a typical ankylosing spondylitis, wherein when there is arthropathy, normally if the central joints are involved, it is seronegative arthropathy. If the peripheral joints are involved, it is seropositive arthropathy. In this particular case, look at the central joints, the costotransverse junctions, the sternoclavicular joints are all involved in the arthropathy, which are difficult radiological sites. So this is the fibrous dysplasia we have done at our center here. A seronegative spondyloarthropathy as seen on a whole body bone scan. It's a whole body survey, all the bones and all the joints at one go. Multiple skeletal metastasis as seen on a whole body bone scan. Stress fractures and shin splints, sports injuries can be seen very easily on isotope scans. Infection imaging can be done. A brain perfusion scan to look for microcirculation evaluation of the brain parenchyma can be done, and any confusion states or dementia or the whole spectrum from simple depression to schizophrenia. What is the blood supply and the oxygen consumption of the brain parenchyma can be quantified on a brain perfusion spectrum. A CSF leak, road traffic accident, a CSF leak as seen on an isotope scan. Stress thallium for the heart to look at myocardial perfusion. Now, if cardiologists are here or cardiac surgeons are here, I'll be glad to tell them. I'm sure they would be knowing. Blockages do not really mean that the myocardium is deficient of blood supply. There could be a 70 to 80% to almost 90%. Also, at times, blockages which might not be hemodynamically significant blockages. So, all hemodynamically significant blockages can be opened. Hemodynamically insignificant blockages can be taken up for medical management or lifestyle changes so that things can be done in a proper way. So this is documentation. Like suppose if there is a 70% blockage and it's a hemodynamically significant blockage, that needs to be opened. A PTCA needs to be done. So all these medico-legal things can be taken care of too. Now looking at the beauty of how a myocardium looks like for example, please appreciate this. This is a peri-infarct ischemia During stress, you see less blood supply here. During rest, you see normal blood supply, almost near normal. So this patient will benefit a lot with bypass surgery because the wall motion just might come back to normal. There is considerable hypernating myocardium here. When we talk about viable myocardium, we normally categorize myocardium into 5 categories. Normal myocardium is viable myocardium. Reversibly ischemic myocardium is viable myocardium. Stunned myocardium is viable. Hibernating myocardium is viable myocardium. And peri-infarct ischemic myocardium is viable myocardium. If there is no viable myocardium, the best of surgeons usually would not improve the wall motion of the patient post-surgery. So the surgical outcomes can be predicted on these scans. Thank you very much, and if there are any questions, I'll be glad to answer.
Thank you, sir, for giving us this big view of nuclear medicine. I think question and answers can be tackled on lunch table. We will give it for it. Seems to be eager. Thank you, sir.
Thank you.
Thank you, sir. Now I'd like to request Dr. Sanjay Pandey, sir. Please felicitate Dr. Avdesh Pandey, sir, consultant nuclear medicine. Approaching towards the end of the Subharti surgery update 2022, let me take an opportunity to mention about the poster presentation winners being organized yesterday. In the PG section, the first rank goes to the topic male breast basal cell carcinoma by Dr. B. Jaya Krishna Reddy from TMMC Moradabad. The second prize goes to the poster purple urine bag syndrome by Dr. Mohammad Adnan from Kalpana Chawla Government Medical College, Karnal. Third prize goes to the poster cerebral volvulus presenting with intestinal obstruction by Dr. Abhishek Kumar from Kalpana Chawla Government Medical College, Karnal. Coming to the UG section, the first prize goes to the poster iatrogenic foreign body in bronchus, a rare consequence of emergency intubation in pediatric age group. The winners are Sakshi Sharma, Rohit Kujwa and Devanshi Khatri. The second prize goes to the topic peripheral primitive neuroectodermal tumor of the upper limb by Sara Afzal. And the third prize goes to the topic ruptured liver abscess by Palak, Priya and Ripi. So these are the winners, and now I'd like to request Dr. Malika Rai Sinha to extend her vote of thanks.
A very good afternoon to all. I deem it a great honor and privilege to propose the vote of thanks on this special occasion. First and foremost, I thank our special guest, Dr. B.K. Jain sir, who despite his busy schedule has found time to grace this occasion. I also express my heartfelt thanks to Dr. Sudhir Rathi sir for his valuable contribution. We are grateful to our revered organizing chairman, Dr. M.K. Maheshwari sir, for his words of encouragement. His able guidance has always encouraged us. We thank our principal sir, Dr. Y.P. Gunga, our vice principal, Dr. Satyam Khare sir, and our patrons for their unstinted support for this conference. Our heartful thanks to our professors for their valuable contribution, guidance and encouragement in all our efforts. I owe our special gratitude to the organizing team and surgery residents who have worked hard to ensure that this conference becomes a memorable success. I thank all the distinguished invitees present here accepting our invitation. Last but not the least, I thank the event sponsors like Walter Scholar and Infama for supporting us in their endeavor. Hope all of you have enjoyed and taken back as much from the CME as we have. Once again, I thank all of you for your attention. Thank you very much.
Otherwise,
Now we can all proceed for lunch in the ground floor.